a formal meeting of the board. I have apologies for absence from Damien, Kathy Winfield, Alan, nice to see you. Danny, in a place, good to see you. And Lucy Davis, who apologised to me. Any more? Am I good there? Yep. Yeah. Thanks. Okay. Declarations of interest, are they all normal? Nothing new to add. Thank you. Minutes of the meeting on the 6th of September. Are they okay? Can I cover in that both the private session and the ICB annual general meeting? Are they all right, everybody? Take silence as assent. Outstanding actions. I think we haven't done enough on outstanding actions. Going to bring them back to a future board meeting, and I'd like them to come here maybe every quarter or something, just so we're on top of that. Yes, Leslie.
Can I just have something on action, please? I think at the last board meeting, Christine asked us all to commit to doing an EDI objective, a personal EDI objective, and I felt like that should be on the action log just to make sure that we do it.
Really good idea. Okay, so let's pick that up when we do the action log, which I think will probably be January. Thank you for. I've forgotten that actually, Leslie. So that's really helpful. Great. We now have a storytelling. We've got Sarah and Lucy. Lovely to see you. Are you doing the introduction, Wendy, or?
I'm happy for Sarah and Lucy.
Okay.
Straight into it.
Okay. Sarah, shall I hand over to you?
Yes, lovely.
Nice to see you.
Thank you. So good morning, everybody. I'm Sarah Bull. I'm the Programme Director for Mental Health in the ICB.
Good morning, I'm Lucy Hinchliffe and I'm Commissioning Transformation Manager at Barnsley Place in the ICB.
Thank you for inviting us today. What we're going to cover for you today is we've got a young lady from Barnsley who has very kindly shared her story with us around her journey in eating disorders. So we are going to use 10 of our 15 minutes for you to hear from Alicia about her experiences. We will, it is a 20-minute video, so we're going to stop it at 10 minutes, but we'll make sure the link is shared afterwards so everyone can hear the full story. And I'm just going to put my hands up and say, we stop it about when she's just going to dip into the things that aren't quite right with the NHS. I just want to be clear that we're not trying to stop it on purpose at that point. And we do want everyone to listen to the full video when you get the chance. But over to Alicia.
Kitchen, and this is just a little video of my experience in mental
That
health
turned up a bit
with anorexia. I've had an eating disorder for several years, but I've only really had help with it over the last few years. Last year I was hospitalised, so I've been across CAMS, SEDS, which is Sheffield St George's Clinic, and I've been to Riverdale Grange, which is in Sheffield, and I was hospitalised in Barnsley Hospital. My eating disorder was a very strong, well it still is, but I used to weigh all my food, so I had a lot of trust issues with food. I used to weigh pre-packaged food, I used to weigh everything on my sandwich, lettuce. I had a lot of trust issues with it, because if something said a certain gram on this package and if it said a certain number and it wasn't on the scales, I can't trust anything. I was over exercising, walking loads, counting my steps, walking around my table when I couldn't go out, doing workouts. It pushed me away. I became unsociable. I couldn't do stuff with my friends, and it just consumed my life, and I wanted to change, but it got to a point last year where I did have to be hospitalised. It's come to a point now where I have been discharged from the inpatient service. That was October last year, and I'm back with the CAMS team in Barnsley. It's always a roller coaster. I've dropped weight since being discharged, but it keeps going up and down, and I'm trying to work on stuff mentally, because I know that it's a mental health disorder, it's not just about weight. Like, I am still underweight, and it's hard to accept that. That's the worst thing, because you want to be same as everyone else, but you have to eat more than everyone else. You want to do stuff like everyone, but you feel isolated because you have your own routine, and it's very hard to cope with. But I know that I need to challenge myself mentally, which is the worst thing, and I might cry through it, but that's fine. So I do challenge myself regularly, because sticking to a routine is just, where am I going to get? I'm going to be in the same thing the rest of my life, and I don't want to do that. So I do have a challenge jar. Hang on. The routine of doing that, and that might be a challenge where it's a fear food, or it's eating something where I don't know the calories of, it's a takeaway, it's something that I'm not used to and something that's scary for me. Coping strategies, I try to talk to people who I feel safe around, talk as much as I can. I'm very open about my eating disorder. Most of my friends and family know. I have a really caring and close boyfriend. I have moved away from home, but me and my mum are really close, but I don't speak to her as much. But I'm finding uni life very good, and I'm coping well at the minute. But yeah, it's just about finding a good community and feeling that you can talk to people, which is good about mental health services if you have contact with them, because you can talk to them for if you need them, and it just puts you in a better headspace because you need them people. You feel very lonely when you have anorexia because you have loads of voices and you don't know what you're doing, so you need reassurance from people all the time to make sure you're doing the right thing, even though you know that it is the right thing. You feel bad for doing that, so you need a lot of reassurance, and that's where you need these people, because yeah, you might get annoying sometimes, which I always feel guilty for, but without them people, you won't get anywhere. You really wouldn't. But that's where you know who you need to surround yourself with, and just block everyone else who's triggering, and remove yourself from triggering environments. What I found helpful in services is having regular appointments. So I have weekly appointments, sometimes it's twice a week, or even a face-to-face meeting, and then a phone call, just so I can talk and get stuff off my chest, talk about the challenges I've done and what I'm doing in the week and how I'm feeling. It's definitely important in services to make sure you're having the same staff, because you open up to these people, you feel safe with them, you tell them your life story, they're the people who's helping you recover and change your future. Half of the time you don't want to recover, but you put trust in them people. So it's hard to explain, but they know your story, and they feel like, this might sound weird, but they become family to you in a way, because yeah, you trust in them people, and you need the same people along your journey. If not, you're gonna fall down, because they don't actually know you like the new people. Do you know what I mean? So same when I was inpatient in Riverdale Grange, it really helped how I had the same staff, and they saw my journey through, and I liked how they saw how I was at the start and when I got discharged, in that they were always there for me. And because I was away from home, they did become family to me. I do know now that the nurses and most of the staff from Riverdale Grange aren't there anymore. So if I was still there, that would have a really bad effect on my recovery, I can't lie. So I think it's very important as well for staff to stay in the business, which obviously is hard because of pay and everything else. And I realise it's a frustrating job to do because you're working with mentally ill people. But it's very important for recovering anorexia people to have the same people, like the same staff on, and make sure they see them throughout. It's also about the staff liaising well together, so everybody knows about the patient's recovery and their needs and what they're feeling, on how to like recover and how they want to do things going forward. Because then again, when you talk to these new people or when you have a conversation with them, you feel like they know you. For example, when I went to SEDS after being discharged, they still remembered everything from before when I went. So this was before going in hospital. I had a few appointments there, which were like 3-4 weeks, and then I hadn't seen them since. So that were like, what, 6-9 months after? No, it would have been longer actually, but they still knew everything about me because the liaison between obviously CAMS and SEDS, and then they wrote everything down. She checked through my notes before she saw me, and I felt comfortable straight away when I went back because I felt like they actually understood me and they remembered, and I felt more invited and safer in that environment. But yeah, it's just, for me, like with a team in mental health services, it's about having someone who you can trust, you feel safe around, who motivates you, and you don't feel bad for opening up to them about your sneaky little habits that you do, because I do that. Your anorexia is always going to sneak in at some point. It's hard to stop it sometimes, but yeah, it's about being honest and open with them, knowing that they will not get mad at you, knowing that they understand where you're coming from, and it's okay to open up to them and tell them these, because they can help you with strategies either to stop that, or they can again reassure your anorexia that, and reassure yourself that you shouldn't do that, so then next time you won't do that. Again, reassurance. It's important to have flexible appointments. That also helps because obviously with school and college, and you want to be more sociable when you come out of services or being an inpatient. Obviously, it's nice that CAMS and other mental health services like SEDS, they've been very flexible with me. And again, the best thing is when you can't travel much or you don't live close to the services, home visits, where CAMS have been really good with that. I haven't had home visits from SEDS. That would have been very helpful because I'm originally from like the Barnsley-Rotherham area, and transitioning to SEDS was very hard. My mother don't drive and my dad doesn't stay in the house a lot to use the car, so it was asking other family members, and it was really difficult, and it was a long drive with traffic as well, and then I'd have to, if not, get a train and a bus there, which again.
Pause it there. So as I said, there is a little bit longer on the video, and we will circulate that round so everyone can pick up Alicia's story again. But I hope that you've all learned something from listening to her story and her journey, and just I think some of those helpful reflections. I think it's things that we talk about all the time in terms of our workforce, consistency for our patients, and creating a supportive environment. I mean, she was just moving in then to talking about the difficulties with having to go to services rather than services coming to her. So lots of things for us to consider that we do all talk about. So I'm just going to give you a very, very brief overview of what we're doing across South Yorkshire in terms of our eating disorders work programme. And Lucy's going to tell you a little bit around what's actually happening in Barnsley, which is very much in response to stories that have been shared by patients. So We've come together as an ICB with our 2 mental health provider collaboratives. So that's the Specialised Commissioning Provider Collaborative and the Mental Health Learning Disabilities and Autism Provider Collaborative to have a really joined up approach to improving eating disorders. So we've set ourselves a vision which is about supporting individuals who've got an eating disorder by bringing hope and belief to their recovery journey. We want to help and support them, their family and friends, so they can help their loved ones recover whilst also looking after their own mental health. And we want to do that by providing a timely and equitable approach that's evidence-based, clinically led and patient-informed. So as a system, we've all signed up to that vision. And the programme of work that we've put in place focuses around 5 key areas. So one is focusing on the eating disorders care model and the commissioning approach across South Yorkshire. We have a lot of disparate eating disorders, and in some places we don't have any provision at all for certain parts of our communities. So we want to look at that pathway and ensure that in the very minimum there are no gaps, but actually what can we do to maximise and get the most out of the finances that we've got, the staffing that we've got, and what's best for our patients. The second area that we're going to be working on is strengthening some of the working across our acute trusts and with primary care, with a specific focus on medical emergencies in eating disorders. The third area is to develop a South Yorkshire-wide pathway for avoidant restrictive food intake disorder. This is the acronym is ARFID, and people with neurodiversity often present with this condition, but there is nationally no service for it, but it's something that we see increasing within South Yorkshire, so that's a specific focus for us. We're also developing a workforce and training plan, and then lastly putting together a community of practice where we're focusing on lived experience, relationship networking between our staff. And to support all of those groups, we're putting in place a co-production group that will be commenting into all of those groups, and in terms of sort of our governance, holding us to account really on what we're trying to deliver. So that's just a very quick whistle-stop tour of what we're trying to do system-wide. And I'll just let Lucy update on Barnsley.
Thanks, Sarah. So Barnsley signed up and part of this programme work, but alongside Doncaster Place, both places have a small amount of funding to fill some of those gaps in service. So that's that adult community disorder pathway. So we're hoping to get something in place by the 1st of April to fill that gap, focusing on in-reach into acute hospitals, transitions, and that sort of classic secondary care support for patients like Alicia, so delivering support into people's homes. So we're exploring doing that together due to expected activity numbers and difficulties in recruitment and retention of specialised staff. The pilot will feed into the broader programme of work. I'm sure there'll be lots of learning going forward.
That's everything from us. Just happy to kind of have a discussion or take any questions.
Brilliant. When did you want to start?
Well, first of all, I think it would be great if we can just write to Alicia for sharing her story. It's really a tough gig, I think, for anybody to share their story. So I would ask Sharon if we could, if we could write to Alicia to express our thanks. It's really important, I think, for all of us, and it's John McDonough from Ardash that's leading this part of the programme of work within the collaborative. It's really important that we advance as both place and system. So we're trying to corral action together. We're trying to make some helpful short-term steps. Hence, Lucy's reflection of the work between Barnsley and Doncaster in the short term, whilst we're really face into this, because we understand the form, either letter that we've received into the system, Alicia's story, other people's stories, that we can do better. And we're really keen to face into this work together as a system and make a difference fundamentally. It's really tough. And we heard some of the words that Alicia shared, which is about trust, the significance of trusting people. That's such a big deal. The importance of person-centred care, the importance of families and how we support families through this sort of situation, the importance of continuity of care, the importance of records and how records transition across services. So all of these things are things that we need to face into and we need to make a difference in. And I'm confident we'll do that. And if Mark, you wanted to add anything as part of the collective.
Only part I was going to add with the actually, I think this is a really strong example of actually how system working, collaborative working can improve the service. If you listen to the number of interfaces that Alicia's having, and it's a relatively small set as eating disorders. So I think looking at it holistically across South Yorkshire, that can reap benefits of the ultimate service that we provide.
That's right, David.
Eating disorders is one of our risks within our quality framework because we acknowledge that we've got work to do here. I think we saw an increase in COVID that we weren't expecting. We've had relatively low levels of eating disorders in South Yorkshire. So, and I think the experts would tell us that we're actually likely to forecast that will continue because stresses that have sort of fallen out of the pandemic and that. So I guess, Mark, they are relatively small, but they're not insignificant. And we think that there will be more patients coming through. So the importance of this work and really having a bit of a response, a collective response to, support individuals like Alicia is really welcome.
Good. Speak.
Thank you, Sarah. Sarah, I'm aware that there are some large sector organisations across South Yorkshire who work in this arena. Are there more opportunities to look at recovery and prevention where the is concerned?
Yes, absolutely. So we work really closely actually on this programme. We work with SAIDA, which is the South Yorkshire Eating Disorders Association, that's voluntary and community sector. One of the offers we've made to the VCSE Alliance is around more training opportunities to help upskill our VCSE partners in working with people with eating disorders, and absolutely, keen to ensure that we are working as a full system.
Thanks.
Thanks, Liz. It's just picking up on Wendy's point around trust and also Mark's reflections about the importance of partnership work and integration, because actually, and just thinking about the wider children and people's work, trust is a massive component of that, isn't it? And very often that trust is placed in non-NHS or non-statutory support and partners. I just wanted to connect that with some work that's happening that we're sort of doing as a whole system, but also supported by our Mayor's Office, so our combined authority, where whilst the focus might appear to be on something quite sort of practical and pragmatic, actually really what that's about is really understanding that trusted relationships and really trying to see what more we can do to understand it better. So our partnership working and our focus is right. And I just think it's a really important point for us to be aware of as a board.
Just a couple of points. I mean, the first of all, Wendy, we will certainly write to Alicia and thank you for her story. I think it was just a couple of points. One, I think it was a bit of a build on the point that Will was making, which is around getting upstream and kind of how do you prevent distress becoming a disorder, because what we're hearing is the kind of when the kind of, I suppose, medical or clinical services are responding to ill health, but it's how do we use perhaps our partnership relationships, whether that's with education or the voluntary sector, to get upstream. I suppose the third point, I was just sort of intrigued that the videos ended just as we were about to get into the things that perhaps we need to pay attention to, and I just wonder whether there are some themes that we could that we perhaps share now. Really, it gives us a sense that the sort of actions and response that we're adopting are consistent with some of the things that are not so good.
I think some of the themes are probably things that we hear from all of our patients, and I'll let Lucy come in as well. But one is that sort of it's accessibility, it's access to help with transport, to get to appointments. It is consistency of staffing, and it's around transitions. So transitions, particularly for young people from CAMS into adult services.
Yeah, other points I noted was availability of tier 4 beds which we know is a risk and an issue, and appropriate care for inpatients, being on a children's ward or an adult's ward as a 17, 18-year-old with an eating disorder in an acute trust that's not specialised to support with eating disorders, the difficulties around that, and training for staff as well about eating disorders. So Alicia talks about how, things like the meal trolley would come round without any difference for her as an eating disorder patient. But, no blame there. There's, we need to support our acute trust colleagues with training in that.
Really helpful. Any other points? Wendy?
Just a couple of things really to highlight. I mean, we do really believe that during the pathway work, we could think about some innovative approaches around commissioning. So we believe that could be a bit of a test bed, I think, going forward about where could that take us. We've been working collegiately with Lee and colleagues around that. So we're following that up accordingly. And I guess just telling our story, keep telling our story about impact, really. I think that's really important, that we owe it to the public and those working in this area to really keep this story of our improvement journey alive and well, and somebody quite keen to show that we're accountable, to the public for that. And then finally, just recognising the interdependencies clearly on this work with the Children's and Young People's Alliance and the Primary Care Alliance, and trying to make sure that we're keeping those conversations alive too.
Do you want to go in? Then Will and sorry, Shahida.
I just wanted to touch on the point Wendy and Shahida made earlier. So we were talking about SAIDA, the BCF organisation, and just from personal family experience, and this was before COVID, there was a 2-year waiting list to access that support and service. So I think when we talk about accessibility and availability of appointments, etc., that was before COVID, and then obviously during COVID, that's been compounded and kind of this unexpected rise that we were maybe not expecting. I think the bit that worries me a little bit is a bit like Shafiq's point and Wendy's point about, well, are we thinking differently about prevention? Because some of these disorders, if we can get in there early enough, it doesn't turn to acute. But in order to do that, how far upstream are we going? And just on Wendy's point, that interdependence between the Children's Alliance, BCF Alliance, Primary Care, Acute Trust, how do we connect all of that up and have a vision for South Yorkshire that, I appreciate there's disparate services, and in some parts it can be good, parts it isn't. But I think what would be really good is if we can kind of take that bigger vision picture about it, because actually we know it's getting compounded. It's not a huge amount of people, but there are a significant amount of people. But I'm also thinking about it from a perspective of where other medical conditions can lead to eating disorders as well, and that interconnection between how are we referring patients, how are we referring service users, etc. So for me, there is something about a bit of a focus on partnership and collaboration, which I think could hopefully lead to some innovation and impact.
We've got Will, Ben, and then Leslie. Will.
It was just, so we're hearing some of the practical things that we're doing that we hope are going to be responding to some of the challenges. And I think there is something about, how are we going to do that? And the reason why I say that is because when we engaged with our public, both on our integrated care strategy and our joint forward plan, we absolutely know that one of the things that came out consistent was about access. And also people's ability to be able to access as well. So 2 things that we've heard really clearly. So, and we also said in doing that, we've committed, haven't we? You said, and we did, and we've actually committed to doing some really practical things that impact on care. So I think there's something about us just being really clear about how we're checking out that the things that we're now doing practically are going to be impactful. Because wouldn't it be great if in writing to thank, also there's writing to thank, and there's a bunch of things that we're doing that hopefully respond.
I agree with that. Well, I've got Ben, I've got Leslie, and then Lee. Ben.
Thanks. Yeah, really cool presentation, and thank you for bringing it to us. I guess one of the things around prevention and what could have been early, she says at the start of the presentation, I've had an eating disorder for a long time and I've been in services for a short time. Yeah. Is there any questioning around, could it have been picked up earlier, where the places where we could have intervened earlier? Because I think that's the nub of, actually, with a lot of things, prevention is better than cure, but it's how do you get there at the right time? And is there anything patients can feedback on that? And then I guess the other point I had was really, there's lots of learning from this. That it isn't just about eating disorder services, and actually how do we make sure it doesn't just go into this pathway learning, but actually talk about learning around access issues, the transport issues, and particularly for young people to access services, and make sure that feeds into the collaboratives and other bits of work, and that we continue to capture those stories.
I agree. Leslie and then Lee. Leslie.
Yeah, I was just wondering about the impact on children's education of a condition like this, because quite clearly there's a real link here in terms of prevention and early identification of a problem in working with schools, but also in keeping kids in school. And I've personal experience of a couple of young people that I know who've had a really bad experience in education, where they've been trying to manage their own health condition, schools are not being able to support that in ways that it's helped it to be functional for them about being in school, and they've come out of school as a result, which has a long-term impact on their life chances and all the rest of it, as we know. And I just wonder, I mean, picking up really Will's point and gathering about working in partnership, but have we got any plans to kind of look at the training of how we work with schools as well? Because actually we need to be upskilling those particularly kind of pastoral staff to be able to know how to get people into further help quicker, because I think they're the ones that probably see it before anybody.
Sure, that's right. When do you want to respond to that?
That's a really helpful reflection, actually, Leslie. But I think there's definitely something for us to be perhaps deeper insight from organisations like Chili Pep and other organisations that are working in and around our schools environment, to understand that even better ifs, or what could we do to get even more upstream, what would have helped. Because there's some things around that we can signal out into the BCSE Alliance, for example. Actually, if there's some additional investment we might want to play into this sort of early help part of the pathway, what could that look like, and we can work together as a community to fit into that particular area. So I think there's still more that we can do around gathering insights. There always is. And I think we need to take stock of the membership, I think, of the programme group, so that we can be sure that we've got these interdependencies nailed down, and we've got the right representation. I think about Ben's reflections around, we've got public health bodies, for example, in there that really add value into that space. So yeah, it's a really helpful conversation to inform our thinking.
Okay, I've got two more, then I'm going to finish because we do have to move on. I've got Lee and then I've got Will. Lee.
I was just thinking to build really about first point is, if we're really challenging ourselves, to what extent could our educational partners triage the child and adolescent psychiatry sort of waiting list for us? Because I'm just a bit fearful there's a big backlog there, and candidly, a lot of the cause stuff, our educational partners will understand it better, and it feels like there's a kind of bypass into the NHS, and then we've got a pool of folk there where we go, crikey, if we're going to do something upstream. If we do something really innovative, you'd kind of go, how we get other partners to help in there. That was point one. And the second point was about measurement, really, and really understanding this. And I think we would all kind of go, if you've got continuity care, a set of trusted relationships, your outcomes are likely to be far better. If it's an outreach service that's in your own home, the outcomes are likely to be far better. Hypothesis A. Hypothesis B, it's just easier for the NHS to have a queue that comes into a central hub that delivers services because the services are there. We've got to get a lot better at evidencing personalised care is more clinically and cost effective. If we're not careful, we kind of go, there's a sensible zeitgeist that those trusted relationships and continuity care are important. I think it's really important we're capturing the outcomes and going, no, absolutely, this outreach model, more innovative model, is leading to improvements in the way we're delivering care and better outcomes for patients. I think that's really hard to do.
In answer, I was just thinking about Leslie's question, are we working with education and others? And the answer is yes, but we could always do more. So one of the ways the ICB is doing that is in partnership with others through the Children and Young People's Alliance. And we are doing some innovative work in that space. But just building on Lee's point, are we being ambitious enough? And I think that's a question for us. There is loads more that we can do, and that's only one space that we're working in. You know, Chili Pep is a bottom sector organisation that we're doing some great work with. So yes, we are, but there's so much more that we could do. I completely agree.
Thank you. Sarah, Lucy, thank you. It was great. It's going to be a good conversation. I hope that gave you some feeling that we're serious now. Two things. I want to just say thank you to Alicia again. We will write to her. That's quite a brave thing to do. Not sure I'd have done it. And for a young girl to do that, I think is amazing. So, really good. The second thing I'd say is something that struck me. We talk about staff shortages and staff turnover. Actually, it was critical to her, isn't it, if you have different staff? That's a real issue of one of the weaknesses of staff difficulties. It's not just gaps, it's not just rotas. That continuity of care really matters in some of our services. Some of our services are highly interventional, individual approaches doesn't matter. These services are about relationships, and staff sticking are critical, and there's something there I think we need to think about. So thank you very much. That was great. Thank you very much. Let's move on. You're welcome to stay, but I'm not sure it's the most interesting thing in the world.
If we both got
You both, I go. Thank you. That was really good. I let that run because I thought it was worth a conversation. I've only got something very on my matters, which is last week we had our first ICB EDI group, and this is a group we set up to try and provide some leadership across the ICB, mainly in healthcare, because it is. Two or three things struck me from that, and Shirley was there with another hat on, and Christine was there as well. One is perhaps as the middle class white guy, you think we've done enough? It's absolutely clear from the responses we got from the people. It was a really good open conversation. Very challenging is we have a long way to go, an awful long way to go. We've got a lot that we need to do. I just think it was a good conversation. I would describe it as a sobering conversation. I think is probably the way to describe it. The second thing I wanted to say, there's been quite a lot of publicity recently about EDI and posts. You were in that discussion, you wouldn't have had any doubt about the need to really make a difference on improving our EDI work, both for our staff and for our residents. And as an ICB, we're actually committed to doing that. We have obligations around health inequality. We can't do that unless we really take this seriously. So just for the record, we do have a vacancy in EDI and we will be filling it. It will be subject to the rounds of competition, given what's going on around our RCA, but we will be filling it because actually this is a core part of business. It's not a bit on the side. It's actually core to what we do, and I gave that message out as well last week. Shirley, Christine, whether you want to add anything from that meeting?
It's a system approach. We're looking across South Yorkshire. We come together as EDI leads and directors in the trust to come together and really focus on a few objectives around equality, diversity, inclusion. We've got racism as one of the first ones, and allyship. So we come together jointly, co-produce a program around that.
I think one of the themes that came out, can we not have another beep strategy? Can we get some 2 or 3 things that will make a difference? There's a real sense that would help. Christine, do you want to know anything?
Just to support Shirley, what is the opportunity of collective leadership? So just even in the NHS alone, 8 boards, the 7 plus 1 ICB board, the impact of all of our individual objectives, and so that's something in its own right, our individual leadership, collectively, when we're trying to discuss, not in terms of reference, we're going to have a collective leadership commitment. What are those 2 or 3 things we do as a collective? And then what was our accountability? How do we push up? So that's the work that we've got to now try and figure out. How do we do that? So thank you, Piers, for leading that. Thank you for your allyship. I think we all are who we are. We come to this as allies. I think.
So we will report back here regularly. We were due to be 3 months, but we felt that we needed a meeting sooner than 3 months. And we'll be arranging that in early January, and I'll come back and talk to the board probably in February on that. Thank you for that. Gavin, Chief Executive Report.
Thanks, Chair. So just to pull out a few things from there, since last time we met, we had a really, what I thought was quite a powerful discussion on our integrated care partnership. Just to remind everybody, this is the group convened by our local authorities together with the ICB, and the focus was particularly on employment. I think it was a great example of how we elevate the conversation beyond the kind of scope, the traditional scope, I guess, of the NHS, and think more broadly with our partners, because we know employment, access to good jobs is a critical part of what creates good health within a community. So I was really pleased with that development. So I just wanted to pick that out. In my report, I also referenced the sad death of a child, Yusuf, and David will share more details about the investigation, the learning, and how the system is responding to that. I think it's really important just to note that. I also wanted to update on I think one of the biggest risks we carry within the health and care system in South Yorkshire relating to capital and estates, and that's the Doncaster Royal Infirmary. I feel, given that I've got Richard in the room, Chief Exec, I might give you just an opportunity just to say a little bit. But effectively, a bid was put forward with support of system partners to rebuild DRI on the basin site in Doncaster through the new hospitals programme. But earlier this year, we were disappointed to find that was not one of the new hospitals that was being supported. So in response to that, myself, Pierce, Richard, local MPs, the Mayor, and other partners, particularly Doncaster Council, met with Lord Markham, who's the Health Minister, with the brief for NHS Capital, and had a discussion about where do we go from here. And I think out of that emerged probably a three-faceted plan. One was to identify the immediate and most pressing capital priorities at DRI and seek to secure funding to make more rapid progress. It's worth noting that the Trust has, under its own steam, invested over a number of years, but the scale of investment that's required outstrips the Trust's own resources. So we've got to find a solution to that. I think the second part was working with partners within Doncaster, particularly to look at what services that are currently provided on the DRI site could be provided in a different way, perhaps closer to the community we serve. And the purpose for doing that, one, would be to increase convenience and access, but also to create some space on the DRI site itself to allow an alternative plan which looks to redevelop the DRI site, which clearly is sorely needed. I think the fourth thing I just wanted to mention was we are conscious, and we were tested recently. There was an incident at DRI a couple of weeks ago where I think it was a false alarm, but I think it just highlighted the concern about the potential impact of estates failures at DRI, and we are working with partners in NHS England across the system, etc., to look at our emergency response should there be a failure of a state at DRI. Richard, was there anything you wanted to add to that?
No, probably not, Pierce. There's been a lot of publicity, as you know, in the Health Service Journal, and there was an article published yesterday that references some of the reasons that the department used to explain DRI. Just for the board's record, really, that the reference that's in HSJ doesn't relate to this period in time. So actually, the sort of issues that they identified in terms of system support and/or political concerns related to the period before that new hospital proposal was put forward. So the references to the acute services review from many years ago, and the references to an MP that had actually left by the time that the programme was put forward. But you are right, in terms of DRI is an older site and has been iteratively developed, and as those developments happened, some of the old parts of the building have not received the appropriate amount of capital to bring them up to modern standards, and that's the challenge that we face now, is that some of those bits of the building do need considerable investment to bring them up to catch standard and states assessment. And at the moment, our efforts are on trying to secure enough capital to deal with the immediate pressures. As you've indicated, we've evacuated two significant parts of the estate, and we've been patient twice in the last 2 years. So that's hugely challenging and not something that we want to continue to have to do in the future.
Thanks, Richard, for that clarification. I mean, clearly this is just a kind of a bit of a stock take position about where we are, but this remains, you know, a major priority for the ICB, and we'll obviously keep the board updated as we work with the trust and other partners to make progress. Not really going to say much about industrial action other than that in September and October we saw further rounds of industrial action, and for the first time we saw an overlapping between junior doctors and consultants. Pleased to say that at this moment in time we've no further dates for industrial action, although the consultants are reballoting their members to give them a mandate for further action. We understand there are discussions taking place, so we're hopeful that will lead to a resolution. It is fair to say that we've had, I think it's over 30 days now over the last year of industrial action, and that has had an impact on our ability to deliver services, particularly planned services like routine treatments and investigations. So it is, I think it's something that the system and our partners have managed well, but it's not without consequences and it's not without difficulties. So the longer that continues, the more significant that becomes. Just briefly on winter, I suppose there's two aspects of our preparations. One is vaccination, and I think we've made good progress with our vaccination campaigns, both for COVID and for flu. I think we need to vaccinate about 500,000 people for COVID. I'm kind of looking at Anthony's a master of the numbers, and I think we're probably about a third of the way there. And then I think in terms of flu, about 2/3 of the priority group, particularly nursing homes, we've already vaccinated for flu. So I think we've made a really good start, and we're kind of getting there. But that's a key plank of our response to winter. We've also submitted quite a comprehensive plan around kind of end-to-end, whether that's primary care, working with the ambulance service, community response, hospitals, discharge. We've got a kind of comprehensive approach to trying to improve our position going into the winter. Just a couple of final things. One is Piers has referenced our running cost allowance. So just to remind everybody, it's been mandated by NHS England that ICBs will reduce the amount of money they spend on running costs. So just to make a distinction, this is on our overheads as an integrated care board. It's not a reduction in the money we spend on services, but it does affect this organisation. We're working through a programme of change that involves formal consultation and voluntary redundancy, which we'll complete the consultation and the outcome of that consultation before Christmas, and then move into a period of change in the last quarter as we enact that. But I think it's worth saying that we're approaching this way in a way that is compassionate and transparent. It's in partnership with our staff and organisations. It's clearly a time of great stress for our colleagues, but we're trying to manage this as humanely as we can. But I think it's also fair to say that as we go through this change, our focus on the fundamental purposes of the ICB around improving the health of local people, tackling health inequalities, value for money, all of that remains unchanged, and particularly our focus on partnership working in our places remains undiminished. So in terms of the new, organisational arrangements, we'll seek to use our focus on those issues and not diminish them. And then very finally, Piers, just to say, it was good to celebrate Black History Month in October. Just to remind colleagues around that, I was really pleased to see the launch of the second cohort of the Inclusive Cultures programme, which is a reciprocal mentoring programme to bring together aspiring leaders from minoritised communities together with established leaders to work together to see how do we make the leadership of the NHS more inclusive, because by doing that, I think we're better able to meet some of the challenges we face, both in terms of as an employer, but also in terms of our responsibilities to tackle health inequalities. And probably just a bit of a comment, thinking about Leslie's challenge right at the beginning of the meeting about objectives. I think both David and myself we've enrolled in that course, so we've picked up our responsibility. So no pressure there on other board members, but the sooner you get your EDI objectives sorted out, the better. And I did end with some good news about our AHPs and medicines management teams who were recognised in national awards over the last month or so, which is really great to see as well. Thanks, Piers. Happy to.
Thank you. Any questions regarding?
No question, it's a comment, you know.
Please.
The children and young people's lives with obesity, that I was really interested in that, and interested in particular in it highlighting the fact that children and young people who live in poverty are more likely to be affected, have less access to good, healthy food and those kinds of things. And I just wonder if somebody could just expand a bit about how we're addressing those things, which are obviously wider system issues and are about some of those wider determinants of health that I have to tackle from an NHS point of view. You know, we don't want to wait until kids are going through a service, do we? What we want to do is try and help people to be healthy from the outset. So I just was interested in that.
Yeah. I mean, I kind of order Will from a children and young people.
Yeah, I think it covers all aspects actually. So, I mean, so when we were trying to describe the fact that we're through our children and young people lines, we're working with multiple parts, including education, I think it starts from there. So we're taking that holistic approach to try and really reach those that actually it sometimes is more difficult to, and actually try to think creatively about the kind of support that we can actually offer as well. So I think it's essentially a whole sort of system approach to it.
And I'm just remembering back to the Health and Equalities event and the other influences that a lot of people around the way that certain foods are marketed,
Yeah.
but also the free availability of cheaper bad food, if you know what I mean. And so if you want to fill bellies, then you're going to go for something that you can maximise the money you've got. And so we're working against that, aren't we? It's not just what individuals do, it's what's available to them in their environment.
I mean, it's a great example of what the Integrated Care Partnership is around. It's not just health, the NHS health services responding to obesity. It's about actually what do we do as a system with partners around exactly those sorts of issues. How do you regulate the number of fast food outlets we have near schools, for example, which is helping to drive this. David.
So I think amongst the Integrated Care Partnership and the health public health colleagues, myself in health and others, I know the children and people probably have dipped into this a bit more than we have, but I think it's an area we want to focus on in having, I was going to call it obesity strategy, but that kind of was looking at one end of it, but about what does healthy eating look like? So I think it's something that and acknowledge, is something we aim to do. I think our resources are the smoking probably is our single priority, bringing a smoking alliance, but I think it follows close behind. So I think it's certainly an area of opportunity that we'd look to address.
I've got Moira then Ben. Moira.
Thank you. Again, I was just wondering how we're going to monitor the impact of phase 3 of the Right Care, Right Person implementation in terms of people's mental health needs. Because I'm aware of the background to all of it, and actually we do need to make sure that people with mental health needs get the right support and not necessarily buy the police. It's just there will potentially be an impact. So I'm just wondering how we're going to monitor that.
Do you want to answer that, Wendy? Right, and then I'll come back to you, Ben, if you don't mind. Wendy.
Yeah, thanks, Moira. There is currently a strategic group. We've been refreshing the members of a strategic Right Care, Right Person group for South Yorkshire. We also have a tactical group. And that tactical group is really important because that's the space where we take the learning. So we're really interested working collegiately with South Yorkshire Police that we face into that learning and we adapt and reflect and as we move on with that. We also plan to bring an update report and a learning part of that report into our system leadership executive. It's on the forward plan for that. And I meet regularly with the superintendent in South Yorkshire Police, along with Sarah Gould and along with Adam Leyland from Yaz at Yorkshire Ambulance Service as well. So we can keep our assessment, I guess, of risk alive and well.
It might be worth that could come formally back here at some point. I just find that it's a live issue. We know it is. I think there's something about making sure the board's aware of it. Ben and then David. Ben.
Yeah, I was just going to come back in on Leslie's point around obesity, and I think one of the assurances we can give from other perspectives is we're working on a sustainable food network approach. So we're not working on obesity, we're working on the wider food environment and doing that. And I know Sheffield has got a similar program. I'm sure Barnsley and Doncaster have as well. And there'll be a report going to the Health and Wellbeing Board following in November. So interesting.
I think that's really helpful. Often we talk about an obesity crisis, but actually what we've probably got is a nutrition crisis. where people are not getting the right nutrition in their lives for a variety of social reasons.
David.
I was just go back to support Wendy as the right care and right person. So the Urgent Emergency Care Alliance also sort of has a place to oversee this, because there is impacts on the urgent emergency care pathway. And what we're able to do in that is work a bit more collectively across Yorkshire, and because we have one ambulance service. So although we've got representation on our South Yorkshire group, we're also taking to other avenues.
Gavin, thank you for that. Next agenda item, questions from the public. Andy, do I hand over to you here?
Yeah, please. So, excuse me. So we've got questions from a couple of members of the public. So first from Mr. Don Ferris, who asks about the phlebotomy service in Doncaster that was set up during the pandemic, but is due to come to a close in November. And Mr. Ferris will post his full comments on the website, but he asks about vulnerable and immunosuppressed people who use the service. And really the answer around that is that Doncaster and Bassett Law Trust have got significant policies in place to support those patients who do need to go into the hospital and are immunosuppressed, and also that phlebotomy is available in our GP hospitals as well. So we'll post the full answer to him on there, but he did raise that important.
So this is when we had kind of drive-in phlebotomy type services during COVID. Am I right?
That's right.
Okay.
And then questions from Nora Everett, who I believe joins us online. So Nora reiterates a question that she asked in September regarding NHSE Quality Board recommendations about quality committees. And I think mainly the answer is that our QP committee, QIPPE, the terms of reference are updated regularly. So we'll share the full answer with Nora around terms of reference to the committees. And again, Nora asked a question that she put to Barnsley Place in July around its statutory responsibilities. And again, we'll share an answer on our website about that. So those are two questions that have been asked previously. And then two follow-up questions. Nora asked around the plans for efficiency savings across the ICB, and how we're going to make sure that we follow our responsibilities to involve communities where that might involve a service change. And the answer to that is, when we consider any major change to health and care services across South Yorkshire, we'll always follow the national guidance to ensure best practice and public involvement. And then Nora goes on to ask quite a number of questions around corporate assurance reports, mainly on learning from patient safety events, patient safety partners, and the system coordination centre. And those are quite detailed questions, Chair, with quite detailed answers. So if it's okay, we'll write back to Nora with those responses and we'll post them on the website.
Okay, it's obviously postable on the website as well, so people can see them. Andy?
Yes.
Okay, Andy, thank you. Can we move on to item 10, which is the independent report into child death, which Gavin touched on earlier. David,
Leave item 9 first.
Oh, sorry, place report. Did I leave the place director though? My God, I'm fortunately out of kicking range. I apologise for that. Place report, David, thank you for telling me I'm an idiot. Barnsley, Wendy, can I pass over to you first?
I've got long legs.
Imagine I could forget Barnsley, please.
Yes, I'll just a few highlights from us at Barnsley. Really pleased to receive a visit from Andy Pritchard into Barnsley on the 13th of October, and we were, hopefully, she was suitably impressed with our collective efforts as a system, and we were able to share with her the great success that the Community Diagnostic Centre in the Gospels had. She was able to speak to staff, speak to some patients, and watching the video materials, lots of video going off at the same time, so hopefully we'll share that in due course. And we was able to come and experience the health ticket offer as well in our market space, and there was a queue of people waiting to have their blood pressure taken, and thankfully her blood pressure was in range. So that's good. A few of the highlights for us: smoking. Really pleased to the progress working in terms of smoking at Winston Barnsley. We've seen those improving referral and quit rates, and for the first time, the percentage of mothers smoking at the time of delivery in Barnsley is below 10%. So we need to go further into that space. So really pleased about the effort that our partners have all brought into that space. A couple of other bits, building upon the success of the House of Ticker sort of campaign and approach, our Barnsley Health and Health Alliance, which is our cross-partnership group around prevention fundamentally, have really been building a Barnsley-orientated campaign to really try and get upstream and reach some of those neighbourhoods and those communities that are really present too late, all those things. So I'm really looking forward to that in the next month or so. And a couple of other things just to mention, really, our Proud to Care work is working from strength to strength. We had a great session supported by some individuals in Christine's team to really help us to define our people priorities as a system in Barnsley. Really well attended. Some people from the independent care sector were there. And we'll be also hosting an event in the Metrodome. Please do come and join us. I can share the date with you. And we've got over 70 schools coming and joining that event to really bring to light the opportunities that careers in health and care can bring. So I'm really looking forward to that. I'll leave it there.
Thank you. We'll go through them all and then see if people have got questions. Anthony, Doncaster.
Thanks, Chair. A lot of our work in Doncaster is in regard to preparation for winter, although I think it's fair to say that winter's already upon us. And we have a number of pressures at the moment, which we're trying to address through our also multi-partnership work in regard to urgent emergency care pathways. And as Gavin's already mentioned, that will include some risk planning regarding the DBTH estate and working with partners on that. It's always been clear, however, that our response is wider than health and care. And some of the things in the report I just wanted to highlight. We held GP Improvement Week. There's been perfect weeks in other parts of the system, such as acute care and mental health care. This is the first one that we've held in South Yorkshire around GP Improvement Week, and I was really great to host that in Doncaster. There's a number of themes and observations that were made throughout that. Bear some of those in mind for my later presentation on the primary care access recovery plan, but there's some definite learning that we can take from that to other areas of South Yorkshire, and I'll be taking that through the Primary Care Alliance. We continue our multidisciplinary work on bringing communities together around health inequalities, and we had a particular focus on how we can work together around diabetes, pain management and fibromyalgia. Can never pronounce that properly, but it's in there. One of the things I was particularly proud of this month is that we had a social and digital inclusion celebration event in Doncaster that brought together a multitude of organisations to celebrate the work we're doing really on social and digital inclusion. Just some of the real, it was great really to hear from the from residents themselves and the difference that this is making, and you know, really quite heartwarming. But just some statistics, we've now got over 17 trusted referral partners such as Citizens Advice, Doncaster Job Centre, that can refer residents into our digital services, and that's resulted in things like over nearly 150 devices being given to residents, such as phones and laptops, that have helped with courses and with really access to some of the to the resources that people have across our city. And we've now got the opportunity to impact upon 800 learners across Doncaster into those digital services, and it's been a real success story. Again, something that we're looking to replicate across other parts of South Yorkshire. It wouldn't be a report from me if it didn't celebrate some of our award-winning teams and staff. One thing that we're particularly proud of this month is our work on opioid reduction in Doncaster. A couple of years ago, we were the highest prescribers of opioids in the country in Doncaster, and the work that we've been doing on the pathways has significantly reduced that, and some of the staff were celebrated with an innovation award last month. Finally, not within the report, but members have heard me mention previously that we are undertaking a Fairness and Wellbeing Commission in Doncaster, chaired by Dame Rosie Winterton. We had a stock take on that, and the report is ready to be published early in the new year. that makes very specific recommendations to the response of Doncaster residents that felt there are fundamental unfairnesses across our city that we need to address, and we'll come with a specific action plan. And it'd be good for that to for me to bring some of that learning back to this board in the future.
Agree. Rotherham, Chris.
Yes, thank you, Chair. So quite a few things. What I'm trying to do in this report is give people a flavour for the business that's going through the Rotherham Health and Care Board. So, we talked to this board a lot about the cost of living crisis probably 12 months ago. There's a recognition that it's continuing, and obviously we're trying to re-energise now. There's a whole list of resources now that are available to Rotherham residents. So we're trying to re-energise that and make sure people are getting the support they need, because there is a lot of support in there from both the council and from the NHS. Just in terms of the national awards, Anthony, can't miss out this time, but this is a good example. So this is a scheme where we help patients gradually come off antidepressants and then cease using antidepressants. But it's a good example where we can improve services for patients and get better value for the health parent at the same time. So it just shows that medicines management is a particular area where we're going to have lots of opportunities to do that going forward. In terms of digital, just going through, there's some examples, there's 8 examples listed for digital areas we work in Rotherham Healthcare Record, where we have integrated healthcare records across all system partners, and the Rotherham Health application, which has 22% of Rotherham patients using it. That's to look at medical records, to appointments, to order prescriptions, and there's lots of ways people do that. But the big thing that came out about Health and Wellbeing Board this time was about digital inclusion. I know, Anthony, you've mentioned it. So as we're motoring on with these digital advances, there are certain members of our population, Leslie's nodding because we know the Old People's Forum particularly is one we work with closely to try and work through, but there are many other areas which is an issue. The digital inclusion is something we're going to go big on in the next few months and try to come up with an all-encompassing digital strategy. Just in terms of Rotherhive, going on. So Rotherhive is a mental health and wellbeing support app that's available for all Rotherham patients. We've traditionally looked at debt advice, mental health and wellbeing, physical health advice. We're just launching a new part of it, which is called Life Stages, and it can cover support for marriage, relationship breakdowns, pregnancy, parenting, going to university, menopause, aging and later life. We're just trying to get that whole person view rather than just trying to over medicalise people, trying to look at the whole person, because we know from our experience that that's the best way to assist patients. Just on a slightly operational issue, one thing that's been really not performing well in Rotherham has been access to community occupational therapy. That's something we've prioritised. We've managed to get the waiting times down from 48 weeks to 11 weeks in the last 12 months, and it's continuing to decrease, but that was a key priority for us. It's nice to see that we're getting the traction there. The last thing was the winter plan. So there's a full page on here on the winter plan. I don't like calling it the winter plan. The NHS winter lasts from October to May at the moment. So we only have a winter and a summer in the NHS. So I think I'll prefer to call it a surge, because that's when we see demand for our services increase. So I'm going to have to work on the title of it. But what we did, we looked at what worked well last winter. Extremely challenged last winter. To say we just about managed is probably a fair summary, but lots to learn. And there's 38 actions you see put in place, but they're not just things that happen in an A&E department or things like that. The whole system interventions that we can put in across health and care, primary care, mental health, street and the voluntary sector. And then we've also focused very much on escalation, getting the right care first time, making sure the right services are there for our patients. And just from a system perspective, the key things that we probably need to work as a wider system to mitigate is the impact of industrial action, as that's ongoing. That's going to be a challenge. We've got the cost of living pressures obviously keeping coming through. We've got developing capacity, particularly picked up this morning, was community workforce is a challenge at the moment. We're seeing more complex patients coming and presenting to us. COVID, Ben, I'm looking at you as Director of Public Health. We're just keeping an eye on COVID, but we think COVID flu are going to be very active this winter. We just don't understand quite how wide, so we need to be flexible to that. And Richard, just from our perspective, as Rotherham systems, we recognise we need to support potentially Doncaster if there are serious issues in Doncaster. We need to build that into our surge planning to be able to support South Yorkshire partners if there are issues elsewhere. So that's good. So that's a quick jog through the chair.
Helpful, interesting jog through. Thank you. Emma, Sheffield, please.
Thanks, Jeff. So first item is just around our investment in one of our priorities. So you'll know one of our 5 priorities is building a modern neighbourhood. pleased to say that a report went to our partnership board on the 9th of October and was agreed. So we're focusing on the North East. I talked about that last time. We're specifically focusing on 4 of our medium super output areas. They are Ferngreen and Grimsthorpe, which including Pitsmore, Firth Park, Crabtree, Vale, which includes Page Road, and Surrey Green East. So that was agreed. We're investing in people, as you know, not services. So it's a very different approach to what we're doing. And probably a couple of things that you were talking about, Leslie. So what we're looking to do is to award small grants directly awarding those communities. And we've identified 4 community leaders who are helping us. So we're not going in and saying this is our strategy. We're asking communities to tell us what's important to them, how we support and fund that. So it's really exciting, to be honest. So we're looking to change Sheffield one neighbourhood at a time, and we've got the King's Fund and also New Local, who are an independent think tank who are looking at public reform of services, but also how we unlock community power. So they've been working with people like doing a Wigan deal. So actually, I think we're probably one of the first power systems that actually approach them. So it should really help some of the research. So really exciting stuff. Excuse me. Next item really is around focusing on the physical health strategy for people living with severe mental health, so mental illness, people with learning disabilities and autistic people. Autistic people die on average 16 years earlier in the general population. On average, men with learning disabilities die 20 years earlier than men without a learning disability, and for women with 27 years. These are not, it's just not good enough, it's simply not good enough. So pleased to say that in Sheffield, we've got real focus now on how we support people with physical health needs. And as a result of that, our annual health check position has increased from 18.5%. That's huge. I'm really proud of that. There was also an increase in the uptake of annual health checks for people with learning disabilities from 35% to 85%. And Sheffield is one of 5 places nationally to be awarded a place on the NHS England national pilot for health checks with autistic adults. So really pleased with that. And also, as the council lead, one of the things we know is a lot of these things are preventable. That's the sad thing. People are dying from preventable diseases. So in terms of bowel screening, we had an increase of 29% of people with a learning disability completed and sent that test, which is bowel screening, for the first time. So that's huge. And if we can really improve that rate, we could see a huge difference to that population. In terms of other things going on, Sheffield's Carers Roadshow. Carers are unsung heroes. They often don't get the acknowledgement that they need. Interestingly, we've got 60,000 unpaid carers in Sheffield, and only 10,000 of them are accessing their support. So actually, provide them with support. We know if carers' health and wellbeing breaks down, that has a huge impact on people's lives. So actually, putting support around them is a real priority for us. It's the first roadshow we did. We have lots of events, and we'll really develop that service and that support moving forward. And, you know, not to talk about awards because everyone else does that. We've won a few awards, can't complain with Barnsley, but we have won a few awards around our medicines optimisation team, done some groundbreaking work on asthma and other issues which are there for all to see. But I won't boast about it. I'm not like these three.
Thank you. Really helpful run through of different work going on, but some good themes. Actually, they're quite consistent. Any points people want to raise? Okay.
No, Rick.
Yeah, please. It's all right.
You're going to handle quick enough. There's just something for me that is quite implicit in all of the place updates, isn't it, around the work that we're doing to, I guess, to change some of the things that we're trying to change. So some of the things we're putting in our strategy and plans, isn't it? So whether that's about shifting resources to where there's most need, or whether it's grappling with some of those, you know, big challenging things. So we're really committed to the voluntary sector, but really trying to just find how do we really demonstrate that proof of concept so actually we can develop something sustainable. And I guess it's easy to see in you know, some of these success measures, Emma, that you've set out in a model neighbourhood, and I bet you could do that in any of the places. But I'd be really keen to make sure that we really pick these up, because actually I think there's a real opportunity here to grab a hold of, you know, some of those priorities and ambitions that we've set out. Because I would be really keen to understand what, you know, how do we make, one of the things we're going to check ourselves on is, are we doing the things that we know are going to be impactful and we said we're going to do? They're implicit in those success measures, but how do we really know? So, and it might be that in our places you've already started doing that. It might be in a modern neighbourhood you've got that, but I do think that there's something we should get a hold of in a really thoughtful way, so that we can actually check that we're doing the right things.
I think the thing is, well, some of these things are going to be for 10, 20 years, and as an NHS, we need to hold our nerve. We can't act alone. A lot of the health problems that we face are due to the wider attendance. So it's how do we work in partnership with our communities in a different way. I think some of the, and that's why we've asked for that evaluation from somebody who doesn't usually do these kind of things, because a lot of this is about people, communities, and what matters to them. It's not the normal things that we've measured, but what we're hoping to see is things like, you know, talked about bowel screening previously. It's about how do we make sure those people who live in those communities aren't further disadvantaged because of where they live. And so I think it's going to take a bit of time to build some of that evidence, but and I think we were talking about it yesterday, and Gavin said it was, you know, it's a drop in the ocean, 800k in terms of the Sheffield budget, but it's starting to change, you know, what we do. So I think there'll be lots of case studies coming out, and that we can probably bring here as well.
I just come.
Yeah, and then Wendy.
Because I agree, Emma, and I think that's my point in asking the question, really, because I think we've got to become comfortable with something that's going to take a long time to be able to achieve ultimately those success measures. But there's got to be something that's making us, you know, otherwise someone will come along, won't they, at certain times of pressure and say, actually, you know, are you sure that's doing what you want to do? And actually having some consensus about what we accept as a measure of going in the right direction, I think is quite important to this board.
Got Wendy, then I've got Shirley, then I've got Moira. Wendy.
Yeah, I think there is just something about on this sort of neighbourhood oriented approach. I think there's really something for us to understand about what now looks like. I mean, we're 10 years involved into our neighbourhood model, where there's lots to learn, I think, from that. There'll be lots to learn from Sheffield's approach. So understanding that right now together, I think, as a leadership committee is really quite important. But I just want to pick up the point that Emma was raising about the great work that's taken place in Sheffield and in other places around carers. And I know that supporting carers matters to us as an organisation, and it matters to us as leaders in and of our communities. And there has been an announcement of an accelerating reform fund that is going to be a national cost of 42.6 million. And there are about 12 priorities potentially for places and systems to think about areas like shared lives and other opportunities where we might support carers to grow to effect. To that end, we've agreed that it needs a local authority as a potential one local authority across South Yorkshire to lead that and to form a consortium whereby together as leaders we can build forward a proposition that we might want to pitch in for some of that funding. We have agreed that it'll be Rotherham that will be the lead. I mentioned that to you, Chris. Rotherham's going to take the lead on that, and we'll be working together with the listening folks to galvanise that consortium together. So just something to share.
Thank you. Shirley and then Moira.
Yeah, I'm picking up on Emma's point around people with learning disabilities and the stark evidence that, you know, they die a lot earlier. When you talked about with autism. It all connects, you know, with Alicia's story around eating disorders. It's around, you know, it all fits on the learning disabilities and neurodiverse conditions. But I'm just adding to that when you might die 16 years earlier if you've got a learning disability. But however, if you've got a learning disability and you're from an ethnic minority background, you die even more, another 10 years earlier on top of. So I'm just thinking, you know, these are stark statistics, you know, we are leaders here, system conveners. How can we join up some of what Emma's work is doing here? I know within RDASH, we're looking at people with learning disabilities, and we can't, you just can't have those statistics and not do anything about it. You know, we know about the health checks, the animal health checks, the bowel screening, you know, they can have breast screening, people with learning disabilities. But how can we join that up so it becomes more the norm, you know, that's built in as a universal service that's offered to those communities?
There is something for me, and it touched on what Will said earlier, which is we're doing some really interesting work here. And actually, the place-based reports are really good examples of it. We might be put under pressure later that says this is all long-term work. I want you to concentrate on dot, 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 dot. We need to capture this better.
Yeah.
Even what we're doing, let alone doing more shows. So we can say to ourselves, one, this is the right thing, and two, it's working, as opposed to, well, it's not giving you any return. What are you doing on ambulance waiting times? I'm not knocking that. And I think there's something for us. How do we capture some of this work, describe it better to our public, but also to NHSE and others that says, this is how you make a difference. So there is something about capturing those stories better than we've captured them. There are times when I come here and I think there's some interesting individual stories there, but I'd like to capture the narrative a bit better. Maybe that's something we need to do, and we can think about how we do it, because it's there, but it's not. I don't see it enough, Gavin.
No, I absolutely support that. I suppose a couple of observations. One is I can see how the work being done in each place absolutely aligns with the integrated care strategy and what we've agreed as a system to do. But also, when I listen to each of those presentations, every one of them has got a real nugget. There's something that's happening in one of those places. You think, "Oh, that's really good." So there is I'm not advocating it's one size fits all, but there is something about spread. And I think a bit of a build on Pierce's point. I mean, I think being really able to articulate the benefits and identify those things that are most impactful, it's then about, well, how do we take that learning and apply it right across the system? Because if anything, that's what the the integrated care system ought to be about. I mean, it's spreading the good stuff.
Maura, do you want to come in?
It's really just building on what you and Gavin have just said. I mean, just on a very practical point, I'm just looking at our website, and I'm just wondering whether there's more we can put some of those brilliant place-based stuff in that website regularly, so it doesn't just come here.
That's a really good point. I don't think we make enough of some of this work, Moira, in anything. Shafiq, you wanted to come in?
I think for me, it's about the bleeding obvious. In that, if deprivation and poverty we know is linked to poor health outcomes. In terms of one of our four main aims around, excuse me, in terms of the economy and the spend and social value, the NHS and social care spends millions and millions of pounds. And do we actually look at how that's spent in neighbourhoods and how we can use that pound differently to invest in communities? So I think for me, there's something about what Roger was saying about the kind of longer term change. Can we look at social value? Can we look at the money spent collectively? And can we do that differently? And can we look at that through a lens of poverty and deprivation? Because we know those are key factors in people's health.
Okay, that's a pretty broad issue there, but I think there's something we need to reflect on. Thank you for the place report, and I nearly forgot them. Item 10 is the child death independent report. David, can I
Yes, Chris. So a couple of meetings ago, I shared the sad news of a death of a 5-year-old child who's a resident of that problem. We made a commitment as an educated care board to commission an independent examination of that. And at the beginning of October, that report was published. You will have seen it because I shared it with you, and there was, we published that. But I think I committed to bring this back to the board as well. So we're open and transparent. And what I hope to do in my brief cover paper was to draw out some of the learning and how we might take it forward, because this is certainly not the end of the process of review. So the report link is included in the pack. It looked at the care pathways from the time that Yusuf got ill to hopefully sad death within the hospital. The conclusion was that he had an unusually severe inflammatory response after the end of a 10-day period, despite having lots of medical treatments. Unfortunately, there was no organism that was identified as the main cause for that. As you would expect, the organisations who were involved have put actions in place, and alongside that, there was a number of additional recommendations which are laid out in the report. There's 19 of them. The first section includes some actions and some learning to be uploaded to national, and our regional colleagues are helping us work with that, and I'm getting updates in regards to those. So I think as an integrated care board, I think we are responsible for ensuring that those quality statements which have been published are seen through, acknowledging that some of the actions have already been put in place. So I suppose, I'm taking responsibility as the Chief Medical Officer, who was the executive lead for this, to lead that work. I haven't spoke to Leslie before, but I think QIPI would be the assurance governance route that we keep oversight of this. As you will see, it's proposed that it gets taken through a number of forums, including the System Quality Group tomorrow, so I'll present it there and we will share it further across the regional group. I think once again, it's an opportunity to share our sincere condolences with the family, because no amount of review is going to bring a young man back. So we need to acknowledge that. So the ask today is to acknowledge and accept the findings of the report as an integrated care board, to agree or steer me as to other avenues that we might disseminate this for future learning through our QIPI group, to look towards QIPI as our forum for doing, and just acknowledge that will be, I will present it to the regional meeting as well. That's a bit of a brief oversight of it, Pierce, but I welcome any additional comments or steer from the board. Thanks.
That's helpful, David. I think QIPI is the right place for this to be dealt with. Should we do?
Yeah, I don't know if it's probably more of a reflection, but it's just something I wanted to raise anyway, just the reports and things that I've read. And I just wondered whether race was a factor in care. Is that something that the family has repeatedly brought up in different ways, but I don't see us addressing that in any of the reports in an appropriate manner. So I think maybe one of the steers might be that if there's an unresolved issue, not just for the family, because it's coming out in communities as well where this case has been discussed, I think there is something there about us asking that question, because whether race was a factor in the way that their care was delivered or not, as the case may be, and I think we need to, as difficult as that question might be or uncomfortable as it might be, we need to address it, we need to investigate it, we need to respond to it, and because if we don't, I think it's just going to fester out there.
Respond. I mean, Shahida, that's the role of the board for me, is to challenge, our thinking and not take things accepted. Race was considered within this, and because actually the care provided was in line with what we'd expect, we don't believe that was specifically resulted in any change in treatment. However, you will accept that, or you will see that within the recommendations to the Sheffield Children's Hospital, it was highlighted about our knowledge of cultural sensitivities when it comes to, practice of death and certification and, releasing bodies. So, that is an explicit one within the recommendations that we will delve, into. But I welcome that, and I've made a comment on that, so I'll ensure that's discussed within the forums.
I think it comes also from this idea of kind of cultural understanding and awareness, and also, I mean, I don't want to get into the whole debate about unconscious bias and all of that, but in terms of race playing a factor, I know for some of our ethnically diverse communities, the way that they are perceived in terms of the way that they raise issues of families and patients raising issues with doctors and nurses, that can at times be perceived differently depending on which diverse community they come from. So I'm also coming at it from that angle, David. So for me, it's not about so much kind of medical and treatment response that's given. It was probably absolutely right what was done. But I think in the way that families and patients are sometimes engaged from ethnically diverse communities, I think there is a little bit more learning that needs to take place there. It's not just around kind of the cultural sensitivity around bereavement and death, but I think there is something there about engagement with patients and families of different cultural backgrounds. Not trying to kind of preempt any investigation, but from other examples and from other experiences in different settings, I don't think we always capture that information, and I don't think we always explore it because it's too politically sensitive. We don't want to get into that. But actually, I think if we're brave enough to explore it, we can impact positively the way patients receive treatment and the way they perceive our services.
Great. Moira, you wanted to come in?
Hi, I'm just looking at recommendations in the number which are around communicating with family members and family concerns. So I do agree with Shahid that issue of race and diversity needs to be addressed. In relation to those, the number of 2 or 3 different recommendations for different organisations around communicating with family.
Just to comment in respect of the next steps of my organisation took the report and it was published to basically see if we got any gaps against what the report had identified. Therefore, I think it's probably worth just confirming that Barnsley have done a survey and all. Just yes, that looks quite utility services and what we read and adapted yes before. And actually, then quickly is just confirming what's in place. So I think we noted all sorts of recommendations. We asked things to do action in them. So I think that's additional assurance to David and others that we're not waiting for quickly to make a decision.
Good point, Rich. Alan, you want to add something?
I think it's important to know, Chair, that overseeing a report of this kind that we receive many. It's multifaceted, the response on how we assure and reassure ourselves. So there will be place-based teams and safeguarding teams that also that are involved in ensuring that they work with providers at each of the places, feeding up to what David's describing as our formal QIPI committee of this board into reassuring this board. So that it's not just one route. I think that's one that reassurance that it's multifaceted.
That's helpful. Okay. And we will be looking towards QIPI to follow this up on our behalf.
Yeah, and we do see that, don't we, Alan, that actually in that committee, we're looking at exactly what Richard's just said, have all the trust looked at it. We're not looking at the detail of that necessarily. It's about receiving assurance that they've considered it
yes.
and they've put actions in place. Yes. And I think David picks those things up as do chiefness.
Okay. It goes without saying this is an extraordinarily sad case. A very sensitive case, and the family is still unhappy, and those of us we're aware of that. That doesn't change our obligation to learn from this in a whole variety of ways. And what I'm looking towards QIPI to do is, if you like, to reassure me that learning is taking place, not just at Richard's point really, but not just in the places that received the child, but in all our places. Okay, thank you for that helpful conversation. We haven't been depressed for a while longer. Financial plan.
Thank you. Yes. I'm not intending to put the presentation on the latest display. The paper you've got in front of you is a bit of a stock take.
Yes.
The work that happened in September Trust Board. To be brutally frank, there's no new news in terms of the month 6 financial performance. We're broadly where we thought we would be. We're certainly not on the financial plan. The paper then specifically identifies in front of you the work that we're trying to do in the run up to Christmas. I'm using this language about evidencing as good a financial performance as we can in year. I'm not using a language around delivering break even. Gavin and I had a meeting with NHS England colleagues nationally and regionally yesterday where we presented some scenarios and forecasts. None of them had a break even in them. There was a range of forecast scenarios in there, so that was acknowledged. Very positively, we've done some much earlier work around the medium-term financial plan for next year. What that says is pretty bloody stark about the level of savings we'll need as a system. So on a bad year, we kind of get that number together by the 31st of March. You're going to look at it quizzically. The work we've commissioned from the Trust Board timeout and the SLE meeting is getting us into what should our response to that be then? So very specifically, I think we need to think very intentionally about our improvement capability across the system, how we label those accountabilities into individual organisations, the collaboratives and alliances, getting a bit faster upstream on technical efficiency in organisations, the sort of place allocative efficiency work. Certainly need to do some work with here and just our approach to population health. I shared some information the other day, some quite cute work there. We're doing all about population segments and improvement headroom around frailty, chronic disease, end of life. We need to replicate that work for South Yorkshire. The reason why it's important to do that is we're quite keen to avoid difficult choices. We had a rehearsal of sort of a difficult choice list in executive yesterday. Everybody enjoyed it without being too trite. We observed making those choices would be quite difficult, and it would tend to be denuding resource into prevention, primary care, the very things we probably wouldn't want to do, which needs to be a bit of a call to also have a transformational and integration agenda, really. The result of the NHSE meeting yesterday, very specifically, some money will be made available to systems this week, we are told, for the first half of the year, which acknowledges the running costs of the NHS for the first half of the year were different to that which were planned, linked to industrial action, but other issues as well. We will note the impact of that on our progress. We've got some very specific work to do about elected recovery funding and how does that operate in terms of compensation payments for industrial action. We'll do that in the finance fold. There's then a lot of work for us to do about the control environment we're operating with given how difficult the financial prognosis is. We've got to do some very specific work on where we're spending money as an ICB on primary care spend on medicines and continuing healthcare. We've got to do some intentional work there. What we're trying to stave off through doing this work is avoid some of those difficult choices. So we've got a list of those things. What we weren't told yesterday by NHS England well is get on in and evoke all those difficult choices, because there is an acknowledgement the overall funding situation in the English NHS is quite difficult at the moment in terms of what was planned and the absolute reality. Where we've got to stay is being able to evidence for delivering as good as financial performance in year, building a capability about integration and transformation for next year that avoids some of the worst excesses and difficult choices. I think that's the update is. Certainly we'll come back to the public board in January with the forecast is now looking far more like this. At that point, we'll have something called a forecast change protocol, which will allow us conceivably to change the forecast. The difficulty with changing the forecast at the moment, which is still break even, it's hard to know what to change it to in terms of the big so many moving parts. I think that's as full of updates as I need to give, but I'm happy to take some questions.
A couple of things, make sure I've got it right. We're absolutely clear. We don't think we can hit break even as it stands today. What it looks like is highly variable, and we are expecting some money from the centre, the amount of which we don't know. More concerning, I suppose, is next year looks particularly challenging. We want to put a lot of effort into that. And I guess what that says to me, Lee and Gavin, is that our December informal board looks as though a lot of it is going to be around the money this year, but also what next year might look like. And I realise it's highly variable. I guess I said to you earlier this morning, it worries me, I think, two things: that we don't appear to be on the naughty step given our figures. And, you know, we're saying it could be 100 million away, could be a bit more or a bit less in our range. And there's some others that are really significantly beyond that, which is a worry. And secondly, too, that we're being asked at this stage not to bring in how might you get to break even. My worry is I don't think the money that we made available to the centre is going to get near this, by the way. That's just my view. All of that says to me that we need a conversation in our board development session in December. Is actually, what does the money look like? What might our new year end look like? And what does next year look like? The real risk is the one you've said, Lou, that we get pushed into short-term measures which take us away from the things that we know we should be doing. That's why the bit about let's the best we can this year, but let's take next year very different. I think it's probably the right approach. Any Richard?
It's good to hear the sort of updates. I think it's really useful for us, because I think most organisations probably do what my organisation is doing, which is to do a year forecast in terms of based upon where we are, what would happen in a traditional winter, where are we going to be. Yeah. And we're going to struggle to deliver our financial plan. So we're in the point now of what are the decisions actions we need to take to hit the financial plan. So the reality is we obviously try to understand what level of support or otherwise there is in there. Clearly what that will do is that will impact on the staff at a really difficult time of the year, because once we make those sorts of choices and we make the choices known to the staff begin to worry for all the reasons we would understand. Clearly what we want to do is focus on delivering winter. Delivering winter without having to worry staff about long. But I think it's also about being honest with ourselves. So even if we had all the money in the world, I still think we would face some choices for our services. Because one of our biggest challenges is that workforce is doing some key specialties and some key services. And I think we've talked to this board before about some of those key services that are under real pressure. So I think some of the discussion we've got to have sooner rather than later is that discussion, like not about the money per se, but about what we can reasonably provide to make sure our services are really good quality with the resources we've got. And I do think it takes us as partners to rationalise that ourselves and realise that actually we've got to modernise our thinking about how we deliver services. And in doing so, really try to explain it to the public, because it's the public who need to understand the circumstances, the issues, and why services need to change if we're going to get the support we need to get those services much better than they are now. Because I think the perception, about what we're delivering is perception that's historically based. What we could deliver, I think, with some radical thinking is probably better services closer to people in the way that Gavin introduced for Doncaster. But it's really important we get on with it.
I agree with that. There's some other hands up, sorry. Kevin.
Thanks, Chair. This is I'm trying to find a word that describes the attitude nationally. Finances. I'll continue to struggle with it and not share a word now. But there is something to me about we're doing the best we can. What does that mean in practical terms? Because there's almost a sense of pressure's off financially because it's there's almost like permission, and actually it's not, is it? No. So we're in a position whereby we're not in a place nobody would want to be in making difficult decisions that undermine the sorts of issues that we're talking about, Richard just referred to. But what does it mean in practical terms of doing the best we can this year? Because that's the bit we've got to demonstrate, isn't it? Yeah, correct.
Without being too evasive, we need to see what that national settlement is and how we're going to implement ERF, which gives us a much better view of the forecast, which are the two big variables in there at the moment. Then there's a conversation to be had about what is good enough, nominated in sort of tens of millions of potential overspend, which doesn't get us into some of the difficult choice phase. Now, to be honest, one of our stakeholders, which is represented around the table, already has a £30 million deficit plan, and it has been supported to deliver that through the cash regime that's supporting it. So at one level, you go, well, we've got a sanction to have a £30 million deficit system, because Doncaster and Basildon Hospital has receipt of special payments to keep the show on the road to do that. So as part of getting to break even, there's a little bit of a conceit in there about how does the finance regime operate. We've got a party in the hosted South Yorkshire system that's got a deficit plan of 30 million that's receiving cash support to deliver it. So we've got to elevate the conversation. I think the critical thing for planning next year is we cannot have a normal planning round where we go, let's assume everything we're doing at the moment is sustainable in terms of workforce, operation and money, because we know it isn't. There is a £109 million gap in the plan that we are trying to furtively cover non-recurrently. We know that flows into the underlying position next year. And the regime we've got at the moment, which is extra money arrives in a hypothecated sense to do extra things, seemingly doesn't touch the sides of the £109 million problem we know we've got. And we've got to bridge that gap. So there's quite difficult conversations taking place about elements of money that are hypothecated to primary care to go, well, do we offset that against the 109 or not? Well, we've got to link these conversations together. We can't have them in separate boxes, because there's a slight conceit there about knowing we can't afford the core when we're being asked to do extra things.
I just kind of just to be absolutely clear, having been involved in those conversations with national colleagues, I've got no sense whatsoever that the pressure is off. So I mean, I think there's significant concern around the financial position nationally. Clearly, as an ACB, we are significantly concerned about the financial position within South Yorkshire, and they're the conversations we're having with providers. I think there is an acknowledgement, and probably two things. One, that some things have happened that have had an impact that we didn't know about when we agreed our plan. Industrial action is a good example. I think the second is, I think when we submitted our plan, we were really clear that there were some, I guess, unusual factors that were in play that, I suppose added risk into our plan. And the obvious one was excess inflation, experiencing levels of inflation that we've not seen in the generation really within the NHS with the country at large. So I think there's an acknowledgement that there are some other factors at play which are difficult to manage, but I think there's an absolute requirement that all the basic control measures around, particularly around workforce and pay. Are we absolutely sure that whilst we're recruiting, we're managing variable pay, bank and agency as effectively as possible? Are we absolutely sure that we're draining the lake on opportunities around medicines and prescribing, etc., etc.? So I just want to be really clear with the board that there is no sense that the pressure is on. I think there's an acknowledgement that there are some real challenges. All of those other things, that business as usual, good financial management, I think is more important now than ever, and that's the conversation we're having locally, and that's what we need to in the next few minutes.
One thing I said to chairs last week, I think it was last week, is there is evidence across the country, including in South Yorkshire, that you've increased permanent staffing and have not reduced bank and agency, hardly at all. I think if I was the chair of an organisation, I'd want to look at that in some detail and be absolutely crawling all over that. Because in an era where we're being looked at legitimately for productivity, that doesn't look a good bet, doesn't look a good outcome. And I said to chairs, if I was chair of one of the trusts in South Yorkshire, I'd want to be all over that like a flash with my staff. Because I think we look exposed with that kind of information going around. Yes, there's subtleties there that we might talk about, but on the face of it, I've recruited more permanent staff, tick, and I haven't reduced my bank and agency at all. Doesn't feel like a good position for any organisation to be in, and that does appear to be said, particularly in acute trusts generally. So that's the kind of stuff I'm expecting organisations to look at. This is not a pass.
But what appears to be clear, and I think we need to have our eyes wide open as a board, is that whilst it's really quite helpful that we're not pushed down the routes are reactive but difficult decisions, our system is going to have to make some difficult choices going forward. And unless and until there's a significant financial influx and the people that we need to run service to go with it, those difficult choices we are facing. And I guess this gives us a very short breathing space whilst we're battening down the hatches to actually put in making some difficult choices going forward.
And Richard's point is a really important one. Even if we had a lot more money, I do not believe, for instance, we have the junior doctor availability in the country to run our acute services the way we do in every DGH. We simply haven't got one. It doesn't matter about money. There aren't the ENT doctors, there aren't the rheumatologists, there aren't I could go through 10 specialties where everyone knows we can't run them in most DGHs. This is the year we've got to grasp that because we've known that for several years, haven't we? And the money forces us, but we should have done it anyway. The quality of herbs reasons, because we're bringing in locums at great cost. And probably, no offence, not always great quality. David and then Shahida. David.
A very big point, although this focuses on finances, we can't ignore the sort of performance and the quality impacts that this has as well. And we've got an IPR that we've got areas ordinarily if we had additional funding we would see some benefits. So we're struggling with our finances, but equally we've got some other the parts of the quadrant just need to be considered.
Absolutely. Shahida.
Yeah, I just wanted to kind of just pick up on the workforce question. And I know we talk about recruitment and we know that there's huge gaps in all the things that you've just mentioned, but I think for me, it needs to be a little bit more multifaceted in terms of retention and in terms of flexibility of what we're offering staff. Because, we might be treating some of it permanent, but if bank staff are really huge, I think there's something in there about we've got to have that conversation in tandem with kind of developing the workforce numbers, because for me, it's not just about recruitment, it's also about retention, but it's also about adaptability and having a nimble workforce that can respond, either across region and place if we need them to, but also flexibly that works for staff as well in different ways. So I think that it needs to be multifaceted, or as you say, we're not going to be able to tackle some of these issues.
So it's just in terms of the comment really about things like bank and agency, because one of the things I think would be really, really useful is to get to a common sense of information and data that actually is comparable across the system. So then last year in the round, there were some numbers that were suggested that a number of us knew were wrong numbers, but we used them. And there were wrong numbers because the way the information was or wasn't collected. And I think banking agency is a brilliant one for this because there are some issues in there of working as a system. Because if you work as a system, everybody wants the highest rate that the system has. That's human nature. And that drives some of the sorts of decisions. And obviously, as a system, you are pressed against a number of those quality measures that David's raised in terms of where do you get to. So if we could, it would be really great to have that set of data that we all agree is the killer set of data that we measure in exactly the same way so we can do comparability. Because without comparability, I don't think we ever get to the exam question, we get to the anecdote. And actually what we need now is the exam question, where is opportunity?
I agree. Okay, let's move on. That's helpful. Just forewarning, then I think our December informal is likely to focus on this both this year and going into next year. So I want to make sure I don't want to lose sight of both of the issues, if that's okay. Agenda item 12, emergency preparedness, resilience and response framework. Will.
I'll take the papers over. I do want to pull out a few key things if that's all right. Here's to the board. And actually, Gavin, you mentioned 30 days of industrial action. I can appreciate it was 30 days. So I guess we see them in sequence, but I mean, it felt probably more than 30 days.
36.
So I think from an ICB perspective, it's been quite a busy year as this year from an EPRI perspective. And I don't think I quite realised when I was asked to take on this role that it would be quite so busy, but nonetheless it has been. The reason why I brought this paper is for three things really. One is that we are in the time of year where we're now going through our assurance process. So each year we do an annual assurance to make sure that this organisation, but also our collective organisations and system can respond as well as possible to keep public safe in the event of incidents. We're at the beginning of that. So part of that is the board to recognise it. Remember, we did that last year. I brought a report of the outcome of that in January. Put the link in just to remind us that was our first go. The second reason why I wanted to bring the report is to ensure the board is aware that that is changing. It's changing quite significantly. So what I mean by that is, whilst the assurance standards are pretty similar, the way that we self-assess and I guess the extent to which we and all organisations demonstrate that we're able to respond well to the public is becoming much more involved. And this is a transition approach across England, so it's not happening everywhere at the moment, but it has been piloted in the Midlands. And therefore, it's our turn as North Eastern Yorkshire, which has been agreed nationally and with our regional director, that we will be the next region to take the new approach. There are a few things that I think are important to note about that. One, because of the learning from other incidents and the way that we are asked to self-assess ourselves to whether we're compliant with those standards is much more involved. That has resulted in those systems that have tried it previously as a drop in their compliance. You'll remember that when I reported compliance here in January, I think we were reporting partially compliant at 81%. The bar is already high. It's already a high bar, and most of our organisations actually are compliant or were compliant under the old system. It's highly unlikely that that will remain so I'm flagging that to our board. We certainly will not be anywhere near that rate of compliance. That's not that we're not in a position of being able to respond well in incidents, and I imagine that's the case as well for our organisations. By our very nature of responding well to numerous incidents, and particularly in relation to industrial action. So every time that happens, we are in a level 3 incident nationally across the country. Ourselves and our organisations have to respond. We know that they've responded well. There's a massive impact on our public and our patients in terms of ability to provide everything we want to provide. So in that context, I can give the board assurance that we are much better able to respond
in the case of an incident than we were a year ago, and we're only just over a year old. But nonetheless, as a result of us striving to achieve higher standards as a result of learning, we will take on board the learning. We're open to taking on board the revised framework, but we will see a drop in our compliance across our system. You'll be assured when I bring the full report back of the plans that we'll put in place. So our plan, so for this organisation, but also each of our, certainly NHS Trust and Foundation Trust partners, plans that they put in place to ensure that we're able to respond well to the new framework. You'll see that. What you'll also see is how already the compliance will start to be improving from the moment we started engaging and using the new framework. Some of that is just timing. So we've chosen to take this on board not only at a really busy time, so we're understanding the impacts of industrial action on finance, on quality, and our ability to meet waiting times. There's an impact on people who are doing the role of EPRR. They've been under great pressure for quite a number of years. And some of it is about the cycle. So I bring a report every month, actually, through every board, every other month, through Mark's report, updating you on where we are and anything that's of key for EPRR from this organisation perspective. But actually, it's my responsibility as the AEO to bring a full report at least every year. That's one of the things that we have to, do to demonstrate our compliance. The board is appraised of the full year's work that's happening. So there are things that we have to do. So some of the timings around that mean it's impossible for an organisation to meet some of those governance standards. So I'm just trying to give you a flavour. Sam, who's our EPRR manager, just popped in here, just an example of one of the standards, just to show you the shift. It's in relation to training, the shift in how we demonstrate compliance under the old system and how we need to demonstrate compliance in the new system. That's actually a good reflection of the extent to which we are needing to do that. I see that as a good thing. I think it's a good thing, but there are some impact. The other impact is our role as an integrated care board in this space is changing. So we're already a first responder, a category 1 responder. We have a responsibility for coordinating the efforts of health in the event of an incident, particularly where that incident crosses boundaries. We're a South Yorkshire organisation, so we cover the patch. Previously, under the old fund, the current scheme, our role is to lead and coordinate alongside organisations. In relation to assurance, we've got a role working alongside NHS England to support in the assurance process. That will change next year. They will lead that process as an integrated care board. So I think it's helpful to note that. Those things that I'm highlighting mean that the amount of time, capacity and effort that goes into this is changing quite significantly. And therefore, I think I'm flagging that now because I think I need to bring to the board's attention and a report that starts to help us understand what that changing need is. And how we'll actually respond to that. So I just wanted to flag that. The other thing I wanted to flag previously, when I've brought the report, that there's a bit of a timeline between our board meetings and when we need to share our full and final self-assessment with NHS England, so it can be reported as part of the national EPRR process. I'm asking the board whether we can take the same approach that we did last year, which is we take it through our audit committee and then we bring to the board in January. But we're essentially sharing that self-assessment with NHS.
Does that mean by the end of December?
Yes, it has to be by the end of December. So I'm asking for the board's permission to be able to do that again this year, notwithstanding some of the flags that I've highlighted previously. I think that's about it. Helpful.
Richard, is quick comment really in terms of reinforcing some of what we're saying is that there are a number of systems nationally that have changed the amount and the level of assurance that is required from previous, the NSD being another one, where Actually, what we believe was evidence that would meet the standard is assessed now as not meeting the standard. So the teams have got used to over many years collecting evidence in a certain way and guiding the evidence have now got to collect completely different evidence. And this EPR self-assessment, I think, is illustrating that. So I think once the whole picture's known, all of our organisations will have dropped significantly. And as a result of that, we had to test ourselves. Is that because we've moved in the wrong direction, or is that because the exam questions altered? I think rules indicate that. But it doesn't mean that we're not responding to standards. But actually, the national teams have created a new set work for us to do that we've got to get used to. And it's quite tricky in some of them to understand the questions. The CNST example would be that we as an LNS took the view that if our junior doctors had undertaken a certain training within the organisation and moved on rotation as they do, as long as that training was valid and in date, it would be counted. The CNST view was it wouldn't, and you have to do the training again, which basically means that you've got an extra debt of training to do to comply with the standard, but we're not actually sure what that means in terms of does it bring any additional benefit to anybody in the organisation otherwise. And so at the minute we're getting used to that, and it is difficult to get used to in terms of the change in the evidence that's needed to demonstrate.
Mark.
Yeah, I would just back up what both Will and Richard have said. I think as a provider of mental health services, and we're in this pilot at the moment, and I think particularly in the mental health, I think you'll find we're all non-compliant now compared to being partially compliant previously. And it's all fairly new news, but I think when we've looked at it, we're actually concerned whether some of the standards we can ever meet, just the way that they're established and maybe not quite as applicable for the services that we run. So I think we'll mention first responder training. My understanding is only us can provide one. We will provide it to first responders, and we're not first responders, so we can't ever meet that target. So I think there's a little bit of work to do actually working with NHS England as well on what the standards are and how they're applicable to each sector. And I think we need to get the messaging as well, because as Will said, we've all responded incredibly well to different events in the last 3 or 4 years, and what I don't want to do is actually lead to unintended consequences.
I think we need to pick that up in terms of how we deal with it. Will that help? I'm not comfortable with that as an approach. Thank you. Can we take a 9-minute break? So 11:40 back in. Please. I hate this.
And he's
22 with very little bullying anyway, other than Lee. Okay, item 13, primary care access recovery plan. Anthony, I think you're leading us through this.
Thank you, Chair. So members will recall that in May of this year, the National Primary Care Access Recovery Plan was published, setting out 4 priority areas to begin to address our national access issues. They were empowerment of patients, implementing modern general practice access, building capacity, and cutting bureaucracy. And this was all aimed at addressing the central ambitions to A, tackle the 8 AM rush for an appointment in general practice, and B, that once the patient has had their request answered, they know how that will be managed on the day, rather than having to continually phone back. And ICBs were asked to produce an interim report to boards for November on progress against these priorities, and that's what the paper in your pack does, and what some brief slides of mine will go through. A couple of things of context, if I may. We have always been clear in South Yorkshire that the Primary Care Access Recovery Plan is not an end in itself. We've developed a Primary Care Alliance, as members know, and a subsequent primary care strategy, which is attached as an appendix to this paper, which sets out a more ambitious approach to putting primary care right at the forefront of driving our ambitions across South Yorkshire, and is made up of longer term approaches on how we continue to address some of our issues. And those ambitions include how we address our access issues, our workforce challenges, how we ensure partnership and multidisciplinary working across a range of providers, particularly concentrating on integrated neighbourhood teams, and then finally how we continue to address the art of the possible across our enabling functions such as digital, business intelligence, estates, and indeed a more transformational approach to funding of primary care, which is within the gift of what we have. The second thing to say is that Primary Care Access Recovery Plan, by its very nature, is quite focused upon general practice, particularly in some of its priority areas. But we've been clear through our alliance and strategy that we will give equal priority and focus to all contract areas, particularly pharmacy, dentistry, and optometry, who are key stakeholders on our alliance, and have already come forward with some fantastic ideas and programs of improvement that we're supporting. There's a recommendation within the paper that we come back to the board to give further updates. It would be my recommendation that we centre that around dentistry and dental access, given the vast amount of work that's going on in that area, but also the high level of interest from our residents, but from our political allies as well. So before I go through the specific updates, it's important to note that, like a lot of areas in our system, primary care is very, very busy, and our staff are feeling it. We do deliver more appointments year on year. We are significantly above appointment levels that were pre-COVID now, and we provide those appointments not just by GPs, but by a multitude of professionals, and by a continued combination of face-to-face appointments, digital and telephone appointments as appropriate. Currently, around 41% of our patients are seen within the day, are seen on the day that they contact their practice, and around 75% within 2 weeks. And that's pretty much in line with national levels, a little bit below. But equally, from our GP patient survey, which was undertaken in the summer, whilst there was much to be encouraged by within the results, 56% of our residents told us it was not easy to get through to their practice on the telephone, and 28% of our patients were dissatisfied with the appointment times that they were offered. So that much of the plans that I'm going to go through are trying to address those issues. So Mark, just if we could just put on, and the next one, please. Yeah, so the first one that I described was around empowering patients, and this is allowing patients to manage their own health through a variety of methods, including self-referral. There is a number of self-referral pathways which patients will be able to self-refer into. They include MSK, audiology, podiatry, and we are to increase our self-referrals by 50% at the end of this March. We're doing some good work in those areas. As a risk, it is important to note that 3 of those services have our longest wait. So we need to balance out that ability for patients to self-refer into, whilst those waiting lists are quite significant. We are going good guns in terms of use of the NHS app, although there's further to go. So 44% of our patients can book and cancel appointments online, and 49% of our residents can order repeat prescriptions. But there's more to do in that area, and continual promotion through our digital work, and more services offered from community pharmacy. So we've increased the amount of referrals that are going into, and really putting pharmacy first at the forefront of that. Again, I would have to raise the risk of pharmacy workforce, and we know that we've got some gaps in that area. So whilst we're putting this at the forefront of our plans, that workforce challenge is still there. Next one, Mark, please. The second is around implementing modern general practice, and this was really to do a lot of our sort of digital and telephony work to ensure that residents can get through to their practice in the first instance. So members have heard me mention previously, we've had a good influx of money into South Yorkshire to ensure that all of our practices are a cloud-based telephony system, no longer analog, and and we're going great guns in terms of getting those practices on there. Equally, we're looking at general practice improvement programs with some of our most at risk practices, and that's included sharing of good practice and tailored support to those areas. Next one, please, Mark. This is around building capacity, and is really not a new program, but actually building on additional role reimbursement schemes across South Yorkshire. In July, we had an additional 739 whole-time equivalent staff in roles across South Yorkshire practices. They've included clinical pharmacists, social prescribing link workers, physician associates. That's more people into general practice, more professions. We're doing some serious work now on evaluating the impact, both from from financial aspect, but also from a quality and clinical aspect of what those additional roles are adding. And we're doing a lot of work in terms of care navigation. So work with the care navigation on our front reception desks to ensure that our patients are directed to the most appropriate professional. And then finally, and what I would say probably where we need to do some of the most work on, sorry, Mark, next slide, is around cutting bureaucracy or reducing bureaucracy. And we're asked to concentrate on 4 key areas that are listed there: onward referrals, completion of care, call and report call, and clear points of contact. And this is about really working with other partners in the system to say who is the most appropriate professional to be doing that particular area. And we are going to do much more work with our secondary care colleagues in terms of working through those pathways. We're also, as I say, expanding work across the wider primary care to ensure that we're addressing some of the pathway redesign we can do in pharmacy, optometry, and dentistry. So then finally, if I could just ask board, having read the report and received this presentation, to note the contents of the paper, acknowledge the work that's being done by our primary care providers and colleagues, both in place and system, and our alliance through driving this kind of work. Support the ask of system partners to help implement aspects of the plan, particularly around that primary care, secondary care interface. And finally, consider specific areas that the board would like us to come back on in terms of interim report. I have suggested dentistry sometime in the new year.
Anthony, thank you. And can I just ask something, which is just to make sure I understand it? One of the main criticisms we get is literally the 8 a.m. call, how do I get access to my GP, really? And it comes out in a variety of ways. But I remember doing some work on the long-term strategy with the ICP, and one of the councillors saying to me, yeah, but all everyone ever talks to me about is getting hold of their GP. Forget all this stuff. It's literally as practical. Could you just explain, I think I know, and maybe all of the board knows, what we mean by cloud-based telephony and what's different about it from the responses?
So I defer to the relay.
I think that we know because I think my general practice has it, but I would like to make sure I understand it. Maybe you all know, and maybe the only ignorant man in this room is the chair, in which case that would not be unusual, but actually it'd be helpful to have an explanation.
Yeah, I mean, put simply, it's a more modern technology. So,
yeah. But when I'm ringing in, what does it feel like, Kieran?
Well, the experience should be from a user perspective in terms of obviously accessing the capacity. It won't improve that, but what it'll do is give you much more resilient phone lines. Using cloud-based technology also gives us the ability to be a bit more elastic in terms of how we can direct those calls, the call stack as well. So it just gives us a bit more capability in the cloud to scale the phone lines relative to the needs of the population.
So when I ring my GP, I think it's cloud-based, we can check. When I ring my GP now, he said the phone system says, first of all, it comes back to me. I'm not ringing, and it says to me, "You're number 20 in the queue." If you keep, and I hear it coming down, and that gives me confidence that I'm about to be. And then when it comes down to 4 or 3, you think, "Okay, is that what we're talking about?"
Well, that's part of it. There'll still be some queuing in there because obviously there's only so much capacity to
Yeah, but it's telling me where I am, and all of a sudden I feel engaged in a way that it just rings or it's just engaged. You know, you slam the phone down. No offense, but that's what you do. Is that the kind of stuff? Because actually, this is really important when we talk about it. I want to make sure we understand it.
Yeah, we'll have to bring a more detailed view of
just think because when you go out and talk to the public, the biggest waiting time they talk about is not A&E, it's not ambulance, it's not surgery, it's getting in touch with my GP. And I don't know if that's our GP's fault, but that's what they talk about. We just want to make sure we are doing something to address it.
And it was clearly shown through the patient survey. As I say, 56% of our residents found it not easy to get through on the telephone. So it will be a lot more obvious for patients that is being dealt with. And this, as you say, this is not just a case of getting through to the telephone. Once that phone is then answered, the result won't be we haven't got an appointment, call back tomorrow. Yeah. It'll be this is what we are going to do now in terms of your request, and this is who we will be dealt by.
There's much more triage.
Okay. Sorry, I'm sure you all understood that, everybody, but I didn't. Kevin, and then Lee, and then Wendy.
Thank you, Chair. It was building on your point that it's when people of South Yorkshire tell us that one of their biggest issues is actually accessing their general practice, either at 8 AM or
whatever.
So there's a shed load of stuff going on to improve the position. But I guess there are 2 questions: is how are the public, the patients, influencing and shaping what we're doing? And secondly, how will we know as a board that with all that we're doing, that actually the dial is turning from the patient perspective? I'm just conscious that we've mentioned in the past our IPR for primary care needs developing. So how are we going to be assured as a board that actually all of this good stuff is turning that dial?
Yeah, thank you. I'll pick both of those up then. So in terms of the public and patient influence, this strategy has been involved, has been engaged with using each of those sort of practice for patient forums that they get, and the sort of things that they'd like improving isn't what we haven't heard before, but that's really been at the sort of centre of how we've done that. We've obviously used the patient survey and look to put our delivery plan at based upon those results. Another thing I will say about patient and public involvement, what I haven't described as part of this primary care access recovery plan and the strategy is we really want to look at a communications and engagement approach, Kevin, that is twofold. Obviously listens to what our residents are telling us, but also shows the reality and an honest conversation about primary care at the moment. And it involves the whole part of pharmacy first and self-care and that kind of element. Reducing the rates of DNAs, etc. So there's going to be a national campaign on that, but we're going to localise that accordingly. So the second point about how we're going to know that we're making a difference. Primary care intelligence has often been a little bit of a dark hole, but we are looking at our capacity and demand data, our access to services. We want to increase the amount where it's appropriate for patients to have appointments on the same day and within 2 weeks. So we have got some specific measures around it that we're monitoring through the Alliance.
Got Lee, and I've got Wendy, I've got Ben and Leslie. Lee.
Thanks for the report, Anthony. I think it's really helpful to see it all in one place. Actually, there's loads going on, isn't there? It's a specific point, though, about the sort of hypothecated funding regime we operate in. So at a national policy level, you'd probably go, given that primary care hasn't had the growth in workforce that other sectors have had, the additional role reimbursement scheme is a blooming good idea. Tick. Yeah. When we evaluate, though, I will be intrigued to go, the 109 clinical pharmacists we've appointed and the 42 pharmacy technicians, are they net additions to the healthcare system, or candidly, are they contributing to pharmacy on the high street now being in a parlous state?
Yeah.
So there is this fascinating thing about national policy determination being a good thing in and of itself, going, we need to do something in the investment in primary care. But when it lands within the system, we are trying to deploy a scarce workforce to where it adds most value. That's not to say, I think, if we've seen a swapping of roles into primary care clinical pharmacists, it's a bad thing. But the evaluation of this programme has got to get as far as, was there an unintended consequence? Because candidly, if I've now got a secondary care pharmacy not able to recruit, and I've got no pharmacists on the high street, just because we've got money that's in a box for one specific thing, it doesn't mean necessarily we're doing the right thing by it. Now, we're incentivized to do these things, but we've got to find a mechanism to influence some of that national policy space and then think about how we deploy this on the ground in a way that makes sense to us. Nobody is doing anything wrong in primary care. They're responding very well to a national initiative, but there is a bit of an issue there about the opportunity cost of this stuff and hypothecated funding driving an unintended consequence that we need to understand a bit better.
Yes. And we've been keenly to bring the pharmacy workforce into the Alliance to make sure that we're not having that constant.
If we're moving the same people around, I suppose we're not gaining a great deal. That's the fear. Wendy, Ben, and then Leslie. Wendy.
Thank you. There's a few things here. One is about the efficacy of how practices engage with their population. I think it's a very, personally, my own view is that it's a very mixed bag right now. And I do think there's a role for the BCSC, Health Watch, and local authorities to wire into that to help that process and that approach be much more effective than it currently is. That's one thing. The second thing is for me is about what's the public narrative around all of this. So how do we tell the public narrative that takes actually feedback from the engagement that we have with the ICP, that builds confidence that we know what we're doing and actually what's the return we're going to get from any of these efforts, how people should experience that in their, their day-to-day lives. I think there's a big public narrative. And the third one for me is around, and it's mentioned in the report, and it's a really good report, mentioned in the report is one about significant interdependency around digital inclusion. And we know that the plans around digital inclusion across the 4 places are at mixed levels of evolution, from really the best stuff that we see in some of the places to some places that are really behind the game. And we cannot see a widening of the gap in terms of people's experiences because they just can't afford to pay their phone bill, can't then use the NHS app, plus. So I know the report really mentioned that, but galvanising some action in that space, I think that with time well spent.
Yeah.
Thanks, Anthony. And as Chris knows well, it's one that my members are very interested in our women health scrutiny, keep going back in on. Just a couple of points. So the R's role was really good to hear about evaluation of that. I guess my fear is because of lack of consistency of how they implement it, the evaluation will say it doesn't work, not the roles don't work, it's that we haven't yet got the right model for how primary care should be working. It's R's roles, and I think we've slipped into it around this table saying access to the GP, we need to get away from that, access to a primary care service that people need, and that should be appropriate. So how we do some of that shaping, and I think the conversation about how the public is shaping this narrative is really important. But actually, how are we as services shaping the public narrative of what to expect and what demand should look like and how demand should be met going forward? Because we haven't got enough GPs, it's got to change. The system won't go on in the way it is. So I think that's that's something that's really important. And then these are already made about pharmacy roles, because it's a stage where I've never been in before, where we're going to probably do an interim update to the PNA in Rotherham, because so many pharmacies are stopping services or stopping existing at all. So that's there.
Pharmaceutical needs assessment.
Yeah.
Lovely.
Yeah, I think people have already said quite a lot of the things, but just to kind of add my bit, I think digital inclusion is always an issue for me, and it isn't just about older people, it's about people who can't afford access, or people who just haven't built those skills to be able to use things effectively, and it's usually the people that are already impacted by health inequalities. I know I'm telling you things you already know, so we're just putting them further back behind the curve. I think for me the engagement work is key, and everybody said it, but the engagement work to encourage our communities and people in our communities to use these services differently. So it isn't just about changing them, it's about people accepting that change. And it's, you know, we heard it earlier this morning about trusting a service and trusting the change, and that will only come with time. But sometimes what we end up doing, if we're not careful, is either preaching at people. So we put stuff out that tells them that they're naughty if they want to see the doctor out and see something else. And also we're not really explaining how that service can be better for them effectively. And I wonder whether part of that is engaging people in communities to do some peer work, to look at, you know, how would we communicate this? What would make sense to you? Rather than just putting something on Facebook that says, contact your pharmacy first because we're all too busy to talk to you, which is actually what we do sometimes. So I just wonder whether the engagement work needs to be more co-productive, I suppose is what I'm saying.
Yeah, it's no use us making available wider primary care if everyone thinks that's failure.
Yeah.
Because actually I only ever want to see
doctor anyway.
Just briefly, so to declare my interest, I'm still seen as a GP, but the R's role's got established in a 5-year forward view general practice, which is about to come to an end. So there is an opportunity now to steer future policy decisions. I don't believe it was ever to expand general practice. I think it was to ease the pressures on. So there we have an issue. What are we getting for it, Lee? Well, what was the exam question to start with?
Yeah.
The plan has committed, though, that there is an expectation there's additional appointments. That's a bit of a shift away. So I think our offer needs to be based on these. So whether it's public engagement or that, it can't just be to say I need to see me because I like to see the GP. It has to be based on what are the things as a GP I can add the most value for. So I think that's the core message I would sort of send to our public is, and actually, do you know what? If you free up my time, then somebody who might need it, has access to it, and that's the way we've got to sort of describe this. It's not an all or none problem, but everybody gains from this.
I agree. And I don't think we've made that case of not being seen by a GP, but being seen by a member of the primary care team. Yeah, sorry, Sharon, I didn't see you.
It's all right, but it's building on that as well, actually, on David and Leslie's comment around GP, and because you think GP is the only person to see, and that's like what our public educated, and that's the culture, isn't it? So if you're not seeing the GP, you think we've had a second service. Do you know what I mean? And we've got to educate our public somewhere further upstream to say that actually, well, you can use the pharmacy. But if you're a family that haven't got much money, like, you need to go to the pharmacy, you buy something from the pharmacy, that's cost. They ain't got the money. Whereas you go to the GP, you get on benefits, you get your prescription. So is there a way that the pharmacist can almost prescribe? You know what I mean? So, there's a lot of those things. We've got to address those inconsistencies, really, to why you might wait to go and see the GP if you've got to pay to see a pharmacy or to pay for your what you need. So but I think it's that messaging, really, and I think it comes much earlier. And I think it's also about my background's in health visits, and I'm thinking about parents around, how do we empower parents to understand minor ailments, that the children might present with, and how to manage those minor ailments and have the confidence to be able to deal with I don't know, it might be a very innocent looking rash, you know what I mean? Rather than thinking I've got to rush to the GP or rush to A&E, which is often what our families do. You know, how do we empower and support families around that? That might be work within children's centres and sure starts, but that early upstream stuff. You know, we've been talking about that early upstream stuff, but much earlier than school, but you know, the early years really, and parenting.
That's a really helpful report. Thank you. Firstly. Secondly is we didn't talk at all about dentistry. And it, you know, that's another issue that if I go out, people talk to me all the time. So yes, I think it'd be really helpful if she came back to give us a report on dentistry since we took it over, what we're trying to achieve with that. So, you know, I'm sure the board, no one else mentioned, but I think that's something we should take stock of in the next few months.
Great, thank you.
Okay, thank you for that. Digital data technology update. Will and Kieran, and by the way, how many times has this come up today in terms of accessibility? Will?
I'm going to speak to the expert.
Yeah, Kieran, good to see you.
Thank you. Tips for consideration and notice. I'll take it as read, but if it's okay, Chair, I'll pick up a few points.
Really helpful.
So, first point is it's not everything. It's just a few key pieces that have been identified in this report that the ICB teams are largely actively leading. Of course, the ICS Digital Data and Technology Programme is absolutely vast. So we've just presented just a bit of a distilled view of what we're up to. We do have a newly established Digital Data and Technology Delivery Oversight Group, the aim of which really is to pull together all the threads of that portfolio to really, I guess, ensure that we are assured that we're doing as much as we possibly can to support the delivery of our ICP, bold ambitions, place priorities, and joint forward plan as a key enabling function. So more insight and knowledge will be coming out of those conversations and feeding into this meeting. Another point just to pick out is our fledgling Digital Research and Innovation System Delivery Group, still forming at the moment, but we're hoping that that will be a really key platform for us to identify opportunities for rapid acceleration in innovation transformation. I think that's going to be quite important moving forwards, as long as we're hanging everything that we're doing back to our joint forward plan, our ICP strategy, and of course our place priorities. So hopefully, nevertheless, hopefully the paper gives you a nice potted overview of some of the key things that are going on. Just reflecting the digital inclusion conversations. Back to your point, Wendy, I think there's a clear recognition that there is variation across South Yorkshire, and we have identified some funding to try and spread the learnings in places like Rotherham and Doncaster across the system. And we have actually just recently submitted a bid for some additional funding to get some devices, digital devices into deprived areas for children to support access to care. Final point, just to mention, is very, very soon we will be releasing our ICS data and insight strategy for engagement. This comes off the back of a few months of discovery work and user research with collaboratives, alliances, place partnerships, and so on across the system to really understand what good looks like from an insight-driven system. You know, it's about getting the right data in the right place, both quantitative data, but those patient insights, that qualitative information, analysing that holistically to really not only draw the insights, but draw foresights that allow us to fundamentally advance our understanding of the needs of our patients, improve population health and reduce health inequalities. In the future board session, we will be coming back with a paper around the outcomes framework, which is a key analytical product that we've developed to track the shared outcomes of our ICP strategy. Yeah, I'll leave it at that.
Okay, Kieran, thank you. Any questions for Kieran? David?
Just for Kieran, so we've been supported by NHS providers, and we've been doing some workshop style with our partners. And I think there was an ambition that we might use one of the development sessions for this here, see if people would find it helpful to bring people up to speed about the.
This is such an enabling piece of work of everything else we're talking about. I think it's critical that we get another view back here on it. So yes, you know, when we do that, I'd leave you two to shape, but I think that would be helpful. Yes. Shahida, then Emma. Shahida.
Yeah, I just wanted to touch on the digital inclusion, and I know during COVID we were kind of, particularly from an education student background, we were linking up with young people and giving them laptops and iPads and stuff like that. I think there is something about accessibility to hardware and technology in different parts of our communities and, you know, intergenerationally and things like that.
But also I think there's something about financial accessibility in terms of being able to afford your data, afford the internet and all that kind of stuff. And not that I'm kind of advocating that we should start prescribing internet on our prescriptions, but there is something there about actually, should we be prescribing the internet for our, for some of our patients that can't access it, might make it easier for them to access some of those primary care services. But I also think in terms of digital inclusion, it's taking a much wider approach to it. And where I'm thinking about that, I'm thinking particularly from when we're talking about insights around data. For me, it just sometimes feels like the way we collect data is as a response or a reaction to something. And when we start to think about data collation and baselining some of our data insights in a way that, again, makes it easier for communities to give us that data rather than on us just asking for it when we need it. Because then when we then try to analyze the data, and I'm just thinking about, for example, in terms of demographics, it's a conversation I keep having over and over again with people. Understand your communities, understand the demographics, know who's on the ground, then you'll know what you're responding to. But every time we go back to the system says, oh, well, some primary care people, they do collect that data, some people don't, and it's different. It's about how we standardise for that and standardise that approach as well. So it's great that I love the stuff that's in the report. I think it's brilliant, but I think we've got to be more ambitious as well. So let's get some real insights into our communities, because that's the only way we're going to be able to address some of those health inequalities.
Actually,
that's very well. And then at that point.
So you're dead right about just accessing basic Wi-Fi and things like that. That came out in a South Yorkshire wide survey that we did on digital inclusion. So it's a really good point. And I think on the data point, I think hopefully the ICS data insight strategy will try and move us into a place where we're using data more proactively rather than reactively. A lot of the time we take the data we get and we look backwards. We need to think about, well, actually, how can we use the data to look forward, to plan, to prepare, to simulate, but then also identify where we have gaps, to fill those gaps in so we can better understand the communities that we serve.
Bill, and then Emma.
So just on the insights stuff. So I mean, there's tons going on in this space. I think we've got to think really carefully about what we bring here to make sure we're bringing the right stuff at the right time. On the insights stuff, there's just something I wanted to highlight, which is really quite, for me, it's quite fundamental. Because one of the things that we're trying to do is make sure that there's a real connection between the stuff that we're looking at, data, insights, and the stuff we're trying to do. And we know that we've got all on, haven't we? Where we've already got loads of data, actually making sense of that. There's work that we're doing to try and do that, but it's actually where we don't have clear data coming through. From the insights work, I just think that's really, really important for us to sort of be really, really open and mindful about that. We've got to change what we look at in order to be able to know what we're doing is actually, doing anything. So, we will focus on those things where there's data, even if we try hard to focus in other places, won't we? And I'm just really mindful we spend quite a lot of time with our voluntary sector and really trying to engage really strongly with them, because we know that actually a lot of that data is there, and therefore accessing that as part of our everyday is just so important. But I'm just reiterating.
Do you want to quickly come back on that?
Yeah, I mean, I can't just stress enough the importance of the VCS sector data. It's absolutely vital. But the importance of that only really came to fruition during COVID, where people really was like, oh, actually, it's our VCF sector that got the insights, the relationship, the data that we actually need to, and we're talking about some of those gaps. The frustrating thing was that prior to that, when VCF sector was coming to the NHS and saying, we've got this data, we've got this information, it was either treated anecdotally or, oh, well, this doesn't quite fit into our system, so we can't use the data. But I think if we have a kind of a bit of a mind shift change, and I think that has happened, you can see it in the strategy, where we're really valuing the VCF sector and the kind of data it holds. I think that's going to be another avenue. I think Will's absolutely right, that we can then draw on to make some.
One sentence. We have a discovery and user research workshop next week with the Voluntary Care Alliance on the data and insight strategy and how we can support them in terms of collaboration, digital. So it's on the agenda.
Sorry, I've kept you waiting.
It was just building on your point. A lot of people can't access it, can't afford it. So it's just what work we do with local authorities around, access to public space where people do, people taking off the mobile phone, 20 people in a house. We've got, we're thinking about all the great strategies, but we're still leaving people behind. So I guess my view, what can we do with local authorities? We looked at using personal health budget housing all around supporting people who couldn't afford it. We just can't have a strategy, a thing that everyone's going to be able to act. They're just not. So I think we've got to do more around that. Otherwise, we'll just leave so many people behind.
Yeah, basic right.
That's really helpful. I do think this would benefit from a conversation, an informal board meeting that says, what are we doing? What are our priorities? Because it's underpinning so much of what we talk about. We talked about transformation. Digital is going to be a key lead into that. Okay, Kieran, thank you. Agenda item 15, sustainability net zero plan. Will an update from you?
Yeah, please, thank you. Ordinarily, Peter and Tina would be here, unfortunately couldn't be here. And I remember saying that last time when I actually brought the green plan. So I do apologise because they, as I said, they will be able to do this far more justice than I can. But I just felt really important a year ago that actually this board signed off that green plan. And if you remember, we were in a really good place because as an ICS, we'd already agreed that plan. So it was almost like a gift to this board, if you remember, off back in September. So I thought it was only the right thing to do, given almost years past, just to give you a bit of an update and a flavour of the work that's been done. Remember, there's a 1-year plan within that as well. And essentially what it is, it's the stuff that collectively our system is trying to do to meet the NHS's massively bold ambition to be net zero by 2040 on the things that it can actually directly on. So I just want to just to highlight a few stuff, because actually it's quite a difficult space at the moment. There is absolutely tons going on, but actually the need to really get behind it hasn't gone away. It's still probably the single greatest threat that we've got. Only 2 weeks ago, we were responding with national emergency planning. We were responding to recent floods that are a result of climate change, really. So, we started off our life, didn't we? 42 degrees heat in South Yorkshire and all sorts as a result of that. So part of it is just making sure that we know that this is our core business. The second bit is just highlighting some good work, because actually we have done some good work, in South Yorkshire. We've had quite a big focus on inhalers, and you'll see in the paper that actually we've made some improvements on the carbon contribution to those, which is a really positive thing. But I think also some of the relationships that we're building with other partners, so that actually we can keep this a really, really strong focus, including some of our internal, works as well. So with the estates group, really taking a key sort of leading role in this, particularly given that our estates is a huge opportunity and contributor to that overall ambition. But also working with our combined authority as well. I mean, it's massive. We've got a small but very diligent and committed group that are supporting and leading this work across South Yorkshire that I imagine will go from strength to strength. And there is still obviously the work that we're doing that Lee will probably be able to explain far better than I on some of our real core business. So when we're sort of placing contracts, how are we ensuring that we're getting the best out of that in terms of being able to make sure that they've got sustainability as part of that? And internally as well, because we'll never ever have enough people like Peter and Katrina. That's not necessarily the question. How do we really start to embed sustainability thinking into all of our systems and processes in the same way that we do quality, in the same way we do improvement? So we've got a plan around how we do that as part of our, smaller organisation, but really thinking about how we start to embed some of those sort of core skills as well. So, I mean, the paper I'll take as read, but just wanted to bring a few things that we're doing across some of those key areas, if that's okay.
Really helpful, thank you. Any points or questions for Will? Well, thank you, really helpful. Staff survey progress report. Christine.
Thanks. This is just collating really a couple of key points, if I may. This is probably around a 6-month update really on where we are with staff survey. We carried out this time last year. So you can see from the core paper and the paper itself some of the areas that came out that we needed to focus on as an organisation. And the big long list of actions. Each executive has their own action plan, as well as some things that we're going to bring jointly across the system. So I just wanted to let colleagues know. I think it's fair to say it's hard to gauge whether we're making any progress, particularly in areas like morale, psychological safety. So we tried things like anonymous feedback through Jamboard, which is kind of challenging, but an interesting space to go into. And we do know that morale at the moment is pretty low. So I think it's fair to say it's quite hard to gauge that in the middle of an organisational change. But we are in the middle of our staff survey at the moment, which closes on the 24th. Obviously, wanting to get as many people to respond to that as possible, in spite of quality.
We need to have an area, I think I've said this before to the board, if not in the formal board, in the informal, an air of reality about that. We're doing a staff survey in the middle of a major organisational change and losing jobs. I think to compare it to the previous year will be challenging. We would be stunned if it was anywhere near as good. That's just the real world we're in. In an ideal world, we'd have conducted this survey in April next year when we've completed the work. We know we can't, we get that. But I think we all have to have an air of reality about reading those results when they come out in 6 months' time or whatever. Christine, thank you for that. Can we move on to the integrated performance report?
I'll lead off on that. So what I'm suggesting is that given we've had an update on finance already from Lee, I don't think we need to pick out any headlines unless there's anything else you want to add, Lee. But if we just I just look to lead directors for each of the elements of performance for any highlights that you want to raise from the IPR. So if I could look to maybe David and Alan on quality, is there anything you wanted to raise with the board?
It's been referenced already, Gavin, that we're kind of heading into the winter period. So although we've seen improvements in the urgent emergency care, and we benchmarked fairly well regarding our operational objectives for this year, certainly of late it has been particularly challenging. We have some days where we've got a huge surge. Our main focus has been on non-promoted criteria to reside patients. So really those patients who can continue their ongoing care out with the hospital, that seems to be a real key marker to free up the flow through hospitals and the front end in A&Es and ambulances. I didn't have any particular other quality things to raise. I mean, clearly, in this climate we're in, we do have things that come to light, and we deal with them through our quality forums, but not anything for escalation as such.
Anything?
No, well, I would support that. Obviously, escalation here, Gavin, but yeah, oversight continue.
Thanks for that. Christine, on people.
I think just to say on the people, we're still working on the data. We've shared a few stats. So I just want to know that it says ICB metrics. It should say ICS. It's not for the integrated care board. But we can see things like our sickness absence rates are starting to track up again. And we are growing, as you pointed out, but we are doing a huge amount of work on our contingent workforce and around banking agencies. So what this data doesn't say, and what Richard has highlighted, is quite a lot of specific activity going on in that space. So actually, probably maybe it's worth us, instead of trying to find us to do a bit more of a deep dive on that area, as it's come up as a problem.
Yeah, it just looks, I mean, I might be wrong, but it looks to me as an area that we are going to get some scrutiny on. Even just making sure we understood it would be really helpful.
So we're happy to bring something back around that particular.
Even if it's an informal, I just think it's worth us knowing what the figures are for us and what they mean.
I think that's one of the particular areas where we really do have to get into detail, because we talked about spiralling costs earlier. Spiralling costs of our temporary staff, including covering additional sections, are far greater than our other inflationary costs as a result of the knock-on.
Yeah, I agree with that.
So just doing the numbers, I think we need to do the numbers and the average cost per shift.
Yeah, and I think we almost need to try and do them, netting off the coverage for the industrial action, because that's clearly very different. Look at what you're paying for consultants to cover junior shifts as an example. We know that's not standard agency.
It's not as transparent as you need to see, is that historically, if you're coming an additional theatre session to get the activity done, that's beyond your capacity. You may well pay additional hours. The additional hours rate has been reset as a result of the industrial action. And all organisations are facing a reset of that is greater than the inflationary pressures that we're reporting in the wider economy. And we need to understand that, I think, and because I think that's a knock-on consequence of industrial action that's not immediately transparent.
I agree.
Thanks for the help. Mel, do you want to pick up any issues in terms of the headline operational?
Yeah, that's right. That'd be great. Thanks. So it was just to note that we've now included Rod River's data in the 76% for our standard, which is the first report. I've been reporting for quite a while now, but it's just made its way to this report now. Although South Yorkshire stand at about 70.7% against that standard, which is just slightly below the average. If we touch Sheffield Children's out of that, that does drop to 67.5%. So there's clearly some work that we need to do on that. 12 hours in department isn't in the report this time, but we are going to look at that in because that is a clear indication of the pressures that we've got. Our Cat 2 ambulance response times, we have managed to hold the position for under 30 minutes for the September data. We anticipate that will be different to the October data. And so far we've had a bit more of a rough ride. But it was just to note that the way that the ambulance data is counted is actually changed as of the 1st of October, and that will have an impact. So at the moment, crew pulls up, go into the ED, they pin in, and that's where the clock starts and bake on. So that'll make a bit of a difference. And I've done some mapping against that as well, where we now get that Barnes and Copper River the most impacted. 5.4%, the same as it is sort of like the anticipated area for that, just the Barnes line, and that varies across the trust, and we've got that information if you want it. G&A bed occupancy again, there's a lot of scrutiny on this from a regional perspective, just about the number of G&A beds. Our occupancy has been about 92%, but again, we know that's going to change for the October data. National Health Capital have seen 98% occupancy recently. And Dave's touched on the no criteria to reside. We sat at about 14.7% higher than region on that. And really aware there's a lot of work going on that place across all social care and all partners to deliver on that and be discharged before 5 o'clock. We do need to know that there is a lot of work to do on it. It does need to carry on being in focus for everybody. From the electives perspective and diagnostics, Sheffield Teaching have stuck to their tier 1 trajectories, and actually have been noted by an extreme region as being a positive outlier in managing to maintain their recovery throughout the industrial action. So that was a real positive bit of news for that. The diagnostic performance there continues to be quite a variation between the providers, but we do track slightly above the England average for that, which is great news. Our 52-week wait is going up on an upward trajectory, excuse me, from March up to August. But that sort of is balanced by our other trajectories are coming down. So our 65-week wait to the gains has been increasing reported, and that is steadily increasing. However, our 78-week waiters and our 104 have come down. It's just to note that our 78-week waiters, because Sheffield Children's their ADHD pathway is on their RTT, if you're a treatment pathway, actually that is going to likely track up for us. That's a bit of an anomaly across England, where there doesn't seem to be any consistency about whether they appear on pathways or not. So it is just something that we need to keep an eye out and be cognizant of, just when we're talking about our 78-week waiters, and that is likely to impact going forward as well. There is a bit of work just going forward on it. I think I'll leave it there. I mean, there's some cancer sort of statistics that we can talk about, and obviously we're aware of the work about pig mass, the elective that was launched just yesterday. It's going to be, I think we've got quite a few people on that pathway, I would say.
Can I just understand the ADHD at the children?
Yeah, of course.
Have they changed the way it's counted?
No. So there's some real intricacies about why it appears on Sheffield Children's, and it's around the consultant-led service. So if you were an RDAF patient, for example, you can appear on their 65-week wait list. So there's just a bit of work going across at a national and regional level just to understand.
So there's inconsistencies across the whole country.
Yeah, it's not just us. Yeah, it's nationwide.
I think nationally there's probably 3 or 4 other specialist centres where this is an issue. generally the ADHD waiting list is not reported as part of referral to treatment. So, you know, it is an anomaly, and even in South Yorkshire, there's variation. So Sheffield Children's Hospital is the only organisation within South Yorkshire that reports the ADHD waiting list. I suppose an observation from me would be that the waits for ADHD assessment are extremely long, and I think there is a discussion we ought to have nationally